Yes. Good, good. So you can be correct.
I'm still talking with my housing person. I've seen LinkedIn because that's truly their job. So I understand pieces of it, learn more about it, trading, but we'll see.
Now we're going to be kind of continuing. We're going to be the kind of people that are at there. That's kind of the attention. I don't know.
Yeah, when it started in the state, I was there and was part of state council.
Right.
So I understand the concept, but I did attend several when it started. But being a state person, I feel like so I want to try and make sure that the different behavioral resources in your area is participating. That's what I want to do.
Yeah. Is there potential for
Honestly, it's just me. So I agree. Yes. Just because it's not wanting to get
how do we do it?
so that's what I'm doing. So let me make sure we're aware. Participate. Once I have everybody that's on the program, it's going
Oh, it's good to see you. We'll stay in touch. Thank you.
well, first 89, 79 to 80, and then back to 83. Everybody else had other things to do, and I was I know Stephen Weber, I fight that fight since because of the legislature that's I've already done everything to Stephen. I told him back in the day that Jeff Ringo was the head of the Democrats and kept the one more session.
Good morning. In a second, this will come on. You can't hear me, right? In a second, you hear me. Is that true? Can you hear me? Okay. So, good morning. I am not Chuck Henson. You can probably tell by your brochure. My name is Bob Bailey. I'm retired, actually. Although my wife keeps saying, so when is that actually going to happen? I've been teaching at the law school for 37 years, and one of the things that happened a few years ago was that Angela Drake approached me about starting a veterans clinic. And I thought it was a terrific idea. I served in the Army from 1969 to 1971. I was a Vietnamese interpreter. And Angela went to law, and I went to law school on the GI Bill. Angela went to law school on the GI Bill. Her father was killed in Vietnam. She has a passion for veterans. So we approached the dean with the idea of starting a veterans clinic. He was favorably responsive, and Angela and I went out and raised a fairly large sum of money that allowed us to start the veterans clinic. The veterans clinic has already been remarkably successful in helping veterans with their appeals. Angela will tell you more about that specifically, but we could not have asked for a better person to start and be in charge of the Veterans Clinic, not only because of her passion for what she is doing, but also because she had, how many years of litigation?
28.
28 years of litigation, and she was a very, very accomplished litigator, and she's bringing those skills to help our students to be worthy advocates for individuals who are unable to advocate for themselves or who have been denied repeatedly by the Veterans Administration for benefits that they are due. So we are very, very fortunate that Angela is arrived on the scene when she did. How many people in the audience are veterans? Please stand up if you're a veteran. Are family members of a veteran? Yeah. Those of us who serve, those of you who are family members of those who serve, know that today it's a significantly small proportion of the population who have any connection with military service. You can hear me.
Now it's the live stream.
Oh. Let's see. Doesn't matter. It's not working. So. I want to thank each and every one of you for attending what I think is going to be a terrific symposium that Angela and the students have worked diligently to put together for our benefit. The last thing I want to tell you is I'm a uniform law commissioner, and we, as of next weekend, we're having our first drafting committee for a Veterans Court model legislation. And we want to get veterans courts in every jurisdiction in the country. And we're going to draft, the process typically takes 2 years. At the end of 2 years, we should have model legislation to go out to every legislature in the country to have veterans courts in every jurisdiction in this country. And so please pay attention and watch for updates on how that drafting is going. Without further ado, I want to thank you, and I want to introduce the most important person here besides you all, Angela Drake.
I'm going to use this because I'm a rule follower. I'm an Army brat. I'm probably going to say yes, sir, and yes, ma'am. Thank you all so much for being here. It's heartwarming to see this room filled. I cannot begin to tell you how hard my students have worked on getting speakers here. Amy King, who's our administrative assistant, did an extraordinary job pulling everything together. We have a truly incredible program for you today with many people who have flown in and driven in a very long way to share with you experiences about traumatic brain injury. Before I introduce Amy Odom, I want to let everybody in the room know that war is ugly and bad things happen. And you're going to see some video today, and you're going to hear real testimonies from veterans that are horrific. And if at any time anybody needs to leave the room, don't worry that you're going to offend anyone. The doors are open. Students are going to come in and out between classes. If you hear anything at all today that makes you uncomfortable or triggers a response, please know that you can leave, and we will welcome you back when you feel like you want to come back. So without further ado, I like to run the symposium with military precision because we have so much invested in it, and we have so many talented people here to share their stories. We're going to stay on time, God willing. There will be breaks. Again, if you need to take a break and it's not a scheduled break, the doors are open. Do what you need to do. Coffee and water and snacks are in the back. There will be break service later as well. Our first speaker is Amy Odom. What Dean Bailey didn't tell you is when I took the position with the university and started the clinic, I had never done a veterans benefit case, which is very frightening. But undeterred, because I was optimistic that my students and I would be able to muddle through it, and I see some of my former students, and we did muddle. We fortunately found Amy Odom, who is out of Washington, D.C. She literally edits the book that we use, which is called the Veterans Benefit Manual. She's considered to be the bulldog of the veterans benefit litigation, and she works with us weekly on our files to make sure that we are doing what we need to be doing for our veterans. And thanks to her, we've had some pretty extraordinary results for our veterans. So Amy's going to speak to you today about the law relating to traumatic brain injury, because that's what we're here to learn about. So Amy, come on down.
So while they're figuring this out, thank you, Angela, for that great introduction. But I do have to say, I'm thrilled to be here because this clinic is doing amazing things for Missouri veterans and veterans really all over the country. You've got some great cases, you're doing some great work, and I'm proud to be here. I work for a National Veterans Legal Services Program in Washington, D.C. We're a nonprofit organization, a nonprofit veterans advocacy organization, in addition to doing litigation before the Court of Appeals for Veterans Claims, which is a Article I court that Congress created for the sole purpose of reviewing VA benefits decision making. We do a little bit of advocacy on the Hill. We publish the Veterans Benefits Manual, which I know that all of Angela's students are well acquainted with. I would like to see that. We also do some webinars for people who are interested in veterans advocacy and other impact litigation in the federal courts that have jurisdiction over issues relating to veterans benefits and also active duty military retirement, things of that nature. But today I'm here to talk about how VA has historically treated TBI. But before we get into that, just so everybody has kind of an idea of why TBI is an issue in the veterans community, we have a few videos that show how veterans may acquire this injury. So that was intense. So what is TBI? It's known in the veterans community as the trademark injury of the wars in Iraq and Afghanistan because of what we just saw. Iraq and Afghanistan veterans were more at risk to run into improvised explosive devices or IEDs. And we're seeing much higher numbers of TBI in veterans from those conflicts. And Dr. Oki will talk a little bit more about that in her keynote speech. But brain injuries or head injuries didn't just first all of a sudden appear in Iraq and Afghanistan, right? I mean, people have been suffering head injuries since forever. In really old service treatment records, and we're talking like Vietnam, 60s, 70s, I would see head injuries referred to as post-concussion syndrome. And I was actually talking to Dr. Oki yesterday about this, and post-concussion syndrome is actually a thing. It's an actual valid diagnosis that results from TBI. Because TBI is just a traumatic brain injury. It's the injury, and post-concussion syndrome is something that can occur as a result or as a residual of the injury. But they didn't have the word TBI in the 60s or 70s, right? So this is what I see in older veterans treatment records. So the way that I think about TBI is kind of the way that I think about PTSD, right? So we talk a lot about PTSD today, but we didn't have that word until like the early 80s when it was introduced to the Diagnostic and Statistical Manual of Mental Health Disorders. It used to be called things like combat stress or combat nerves. I've even seen records where, although I'm not a doctor and I can't make a diagnosis, it seems pretty clear to me from a Korean War vet or something that this guy was suffering from what seems to me to be PTSD, although again I'm not a doctor, and it was referred to as immature personality disorder. So TBI is kind of similar in that we really didn't have a word for it until recently. So in these older veterans treatment records, we'll see that they did in fact suffer from head injuries and probably what today would be called TBI, but it's not called that in their records because that word didn't exist. So you can think of ways that older veterans may have suffered a traumatic brain injury. They also had explosions and blasts in Vietnam. They had landmines. And of course, they always had explosion and blasts in World War II. So veterans of those conflicts likely suffered the same kind of injuries that veterans of our conflicts today are suffering. But Dr. Oki will talk about this later. There might be a little bit different. They might be a little different in terms of their characteristics just because of the modernization of battlefield medicine and protection. Also, it can be the result of just a run-of-the-mill car accident. I've had several cases of peacetime veterans who were involved in horrific car accidents during their service and suffered from head injuries in the 70s or whatnot. And they suffered from head injuries that would today probably be called TBI. So those veterans who are seeking benefits from the VA today from the lasting residuals of those injuries can also benefit from the TBI regulations that VA promulgated in response to the high numbers of TBI that we see coming out of Iraq and Afghanistan. We'll talk a little bit about that later. So in 2008, VA changed their rules as to how to rate a TBI, meaning how to determine what disability rating and therefore what monthly compensation a veteran who is disabled as a result of TBI should receive. So just real quick, a little bit of background and general procedures of how to even get VA benefits. Before you even have to worry about what disability rating you should have, you have to first prove, A, that you suffer from a brain injury, residuals of a brain injury, and that B, you had a head injury in service. There was some sort of incident in service that resulted in the injury. And C, there's a nexus or an etiological link between the residuals from which you're currently suffering and the thing that happened in service. That's where most veterans, especially with TBI in the past, prior to 2008, that's where most veterans lose. Because you have to have a medical opinion that says the things that you're suffering from today are a result of this in-service head injury. And you know, that can be a difficult thing to do, and especially, right, prior to 2008, when we didn't even have a name for it. But I should correct myself. We had a name for it prior to 2008, but 2008 is when the VA really responded to the increased numbers of the TBI injuries in OIF and OEF veterans and changed its rules. Because prior to 2008, once you finally prove the connection between the symptoms that you're suffering today and the thing that happened in service, which again, most veterans couldn't do that, then you went on to the rating, you could only get a 10% rating, total, max, unless you had multi-infarct dementia, which in my experience, a lot of the veterans that I deal with who suffer from head injuries don't end up with dementia, at least in their earlier years when they're seeking benefits. So this is, you know, the schedule for rating disabilities said that if you only had subjective symptoms such as headaches, dizziness, forgetfulness, you could only get 10% for all of those symptoms, no matter how severely they impacted your occupational or social functioning. And like I said, excuse me, you needed that diagnosis of dementia to get anything higher. So just to put it in perspective, a 10% rating, especially back in the 70s, 80s, and 90s, was less than $100 a month. I mean, $100 a month. Today, I think it's something like $120 or something like that. So for somebody who was unable to work because of these so-called subjective symptoms of a head injury, but did not have a diagnosis of dementia, they were just out of luck and they had to live on this $100 a month. So why do we think that this was so? Well, you know, I can say with certainty it was because VA felt that symptoms that were associated with the head injury, such as dizziness, headaches, insomnia, forgetfulness, were really just the product of over-exaggeration or malingering. And they said it. So I know I can say that now without saying that I'm just trying to make VA look bad, because this is exactly what they said when they changed the schedule for the 2008 rules and in the Federal Register, which is where they publish the proposed new rules and explain why they're making the change. And they said that the old rating criteria reflected views that were once prevalent, that these symptoms might be due to hysteria or malingering. And I put the citation there so I can prove it. But the good news is, effective 2008, they updated their rating schedule and really took a new attitude towards TBI. And it's no longer treated as, the symptoms are no longer treated as the result of hysteria or malingering. They're taken very seriously, and the VA has really made great strides in not only updating their regulations to reflect this, but also in their adjudication of these claims. So VA was motivated, at least in part, as we discussed, on the increase of TBIs that they see in OIF and OEF veterans. One thing that the VA does very, very well is react to publicity. And so once, you know, the media started jumping on this idea of TBI, and the issue started getting a lot of publicity, VA acted, with relative swiftness, because you have to think it's really hard for VA to change their rules, right? Those of you students who are taking administrative law should know about the Administrative Procedures Act and the notice and comment requirement. So anytime VA wants to make a substantive change to its regulations, it has to go through a notice and comment procedure, meaning it has to provide the public with notice of the proposed change, and that's what they do in the Federal Register, and that's what they did here when they admitted that the old criteria was based on this outdated view that symptoms associated with head injuries were the result of hysteria or malingering. So once they give the public notice, they also have to provide a period for the public to be able to comment on the rules. And sometimes I don't know what the statute says. Maybe there are some really excellent administrative law students in the record in the audience who know off the top of your head how long the comment period has to be. But I know that at least for VA, that usually ends up being like a year, 2 years, something like that. And then once they get all those comments, then they have to issue a new notice in the Federal Register, the final rule that responds to all the comments, explains whether they're going to make a change or not based on the comments, and then also provides the final version of the rule. So it's it's a difficult process for an agency, and especially one like the VA, who at this moment, and still in 2008, was dealing with a pretty large backlog and putting all their resources into adjudication rather than rulemaking. So we do have to kind of give VA credit where it's due, and they did a good job of pushing this through and creating a better rule. So under this new schedule, you can get up to 100%. You can get a total disability rating even without a diagnosis of multi-infarct dementia. Now that said, 100% rating is a total disability rating. That means you are totally disabled. You are excluded. Theoretically, it means you're excluded from the labor market. But the schedule, the rating schedule, the way that it is created is that it reflects the economic or occupational impairment of the average veteran. So you may be above average and you may be able to still function in the workplace with symptoms that would be rated 100% under the rating schedule, but that's pretty rare. So here are some general symptoms of TBI. This is kind of a medical look at what can result from TBI. So something that you see a lot is deficits in cognition. So that's like memory loss, communication issues like the speed at which you're able to recall words, your ability to focus on a given task, your attention, ability to learn new information, the speed of information processing, judgment, decision-making, problem-solving, insight. And then there's also issues with mood. And behavior. So you might suffer from what would be considered inappropriate behavior, but not because you're suffering from a mental health disability, but because it's a residual of the injury to your brain. But you'll notice here that a lot of these symptoms overlap with symptoms that are common to a mental health disability. And that becomes an issue when you're trying to determine what's the appropriate disability rating for a veteran who suffers from TBI and PTSD, which is a very common clinical picture. And we'll talk a little bit more about that. So the way that the VA takes that medical information and puts it into the rating schedule is a little complicated. So VA in the rating schedule identifies these several areas where deficits are often found: memory, attention, concentration, executive functions, judgment, social interaction, and orientation. Orientation means, a lot of times you might see veterans with TBI who have to always have a GPS at their side, because they'll lose their direction in a route that they take every day from work to school or something. They'll all of a sudden one day forget, so they carry a GPS with them. Motor activity, which is just the brain coordinating with, say, the arm to be able to, move a spoon or something like that. Visual spatial orientation. Subjective symptoms, which is what you see a lot, which is the headaches, anxiety, dizziness, tinnitus, which is a ringing in the ears, insomnia, hypersensitivity to sound, etc. And these are the symptoms that you couldn't get more than 10% for under the old regime. And in fact, all of these symptoms you couldn't get more than 10% for if they even counted it as a symptom of the brain injury. But now under the new schedule, I think you can get up to 60 or 70% based on just these subjective symptoms. Communication and consciousness. So consciousness, if I recall correctly, there's only one rating that you can get. Is there another? There's only one rating that you can get, and that's 100%, because that means that you're still in a coma. So one of the students added this image to the PowerPoint, and I think it's pretty accurate of how you apply the rating schedule. It's really a complicated formula. The way that they basically have it is like a table. So each of those different areas that we discussed, you have to score it based on like 0 through 4. So for the person who suffers from really severe subjective symptoms that severely interfere with occupational disability, that person gets maybe a 3 or a 4. And for the person who only has really mild symptoms that only mildly interfere with occupational functioning, that person might get a 1. So if you get a 1, you get a 10%. If you get a 4, you get a 70. If you get a total, you get 100. But you have to score each of those different areas. And if we can go back. Yeah, look at that. That's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 different areas. And you have to provide a score for each of those areas and then go determine which one is the highest, the most severe score, and then you get your rating based on that. Does that make sense? Really? Okay.
You said you take the 7 indicators and then you pick the highest and the lowest, and you get your compensation based on the highest.
Right. So let's take an example. So say we have a veteran who scores a 2 in the memory, attention, and concentration, and then a 0 in judgment, 0 in social interaction, 0 in orientation, 0, 0, and then subjective symptoms gets a 3, and then 0 in the rest of it. So this is kind of typically what I see at the level that I'm at the Court of Appeals for Veterans Claims. The VA does a really good job of taking care of the most severely disabled veterans off the bat, so they never really make it as far as, oh great, thank you. Hello, okay. I don't think this is on. So, this veteran has a 2 in memory and a 3 in subjective symptoms. Well, then that veteran will get the rating just based on the subjective symptoms, because that's where that veteran scores highest. So really, the memory, attention, concentration, and executive functions, the deficit that he or she experiences in that area won't necessarily be compensated, because the veteran is only compensated for the subjective symptoms. But these other issues, dealing with the memory, attention, concentration, and executive functions, could potentially be rated under a different schedule altogether. And we'll talk a little bit about that in a minute. It's on. Okay. So again, using this complicated table, adjudicators assign a single disability for the area in which the veteran suffers the most severe deficits. Now, VA Inspector General they do a lot of like surprise regional office visits, because the regional offices are like the little hubs where all the local decision making is made. So when a veteran submits a claim to the VA, the first level of administrative adjudication where the decision comes from is the regional office. So the Inspector General does some surprise visits to these regional offices and sees how the adjudicators are doing with certain claims. And TBI claims is one of them. Now, according to a lot of these reports, adjudicators have a tendency to overrate using this table. In my experience, and with the caveat that I only see the bad because I take bad decisions to court, VA often underrates using this table as well. So there's still some difficulty in applying it, but unfortunately we don't live in a perfect world. And this is definitely an improvement over what we had prior to 2008. Another really good thing about the new regime is that there's a specific note to adjudicators in this table that tells them if a separate disability is diagnosed, then the adjudicator is to assign a separate rating, right? So let's go back to the example we talked about. If the veteran suffers from some memory loss and it's found on objective testing, and the examiner can assign a diagnosis of cognitive disorder not otherwise specified, that's a valid diagnosis. That's a separate disability. And the veteran is entitled to a separate rating based on that separately diagnosed disability. And that's the way that veterans can have their disability ratings for TBI maximized. Where we see this often is with post-traumatic stress disorder. Like I said, a common clinical picture that you see is veteran with the TBI is also diagnosed with PTSD. Assuming that none of the symptoms that are rated by the TBI rating, so let's go back. So assuming that the rating based on TBI doesn't involve like anxiety, insomnia, neurobehavioral effects, things that are otherwise generally attributed to PTSD, as long as the TBI rating is just based on, say, motor issues or something like that, then the veteran should be able to get a separate rating for PTSD. And then another place we see this a lot is migraine headaches. Oftentimes, veterans who suffer from a TBI suffer from debilitating headaches. And according to the note under the new regime, the veteran should get a separate rating of up to 50% for the headaches, depending on how severely they affect occupational functioning. In hearing loss, in tinnitus, remember we talked about the ringing in the ears? There's a separate diagnostic code or a separate rating schedule for hearing loss and tinnitus. So if a veteran suffers from tinnitus that's been attributed to the TBI, then you get a separate rating for that. It's only 10%, but it helps to maximize the benefit. In hearing loss, there's a separate rating for that. So obviously, this gets complicated. You can't expect the layperson to be able to determine what residuals and symptoms are attributed to TBI, and really even whether those symptoms exist, right? I wouldn't want a layperson administering objective memory tests to veterans, right? So what they need is an examination from a VA medical professional. And it has to cover all of those areas, right? How can you rate a disability under the rating schedule that contemplates all these different areas without medical evidence telling you what are the residuals, if any, and how severe are they in each of those areas. So here's what a lot of people outside the VA and veterans benefits world kind of don't know. When a veteran applies for benefits, the examination is conducted by an employee of a Veterans Benefits Administration, which is separate and distinct from the Veterans Health Administration. So the Veterans Health Administration, or the VHA, is where veterans go to get their medical care. The Veterans Benefits Administration, or the VBA, is where veterans go to get their disability benefits. So it's kind of counterintuitive, right? So if you have a veteran who's getting regular care from the VHA for TBI, you would think that that would be enough, that you can just get that doctor to tell you what are all the residuals and how severe are they. But it's not. They send the veteran to an employee of the VBA, who's a doctor in most cases, sometimes a nurse practitioner, but that's a whole different symposium. And they send the veteran to that doctor for a new examination. So it's something to keep in mind. Another thing is the examinations have to include the tests and examinations that are required in order to answer the question of what kind of deficits does the veteran suffer in each of these areas and how severe are they. Something that I see a lot is that the first area, the executive functions, memory, attention, and all that, in order to get a 1, all you have to have is mild memory loss. But to get a 2, you have to have memory loss on objective testing. So what does that mean? You have to have objective testing to know if you're a 1 or a 2, right? But I see a lot of exams come in where there's no indication that any objective testing was performed at all. And it's just, they just get assigned a 1 for mild memory loss based on the veteran's own self-reported history without any objective testing. Now, just because there's no indication that the testing was made doesn't necessarily mean that it wasn't, but how would I know? How would the court know? How would the adjudicator know? So that could be an issue with the way that the exams are actually performed, or it could be an issue with the way that the exams are documented, but either way, it's an issue, right? So we just talked, well, I just talked a little bit about, whether the VBA examiner is a doctor or not. Basically, you have to be for a TBI exam. VA's own rules say that you have to have specific training and qualifications. You have to be a psychiatrist, a physiatrist. I'm not even quite sure what that is. Physiatrist. What is that? Okay. I'm a lawyer, not a doctor. Neurosurgeon, neurologist, or general clinicians who have completed VA's training module. So general clinicians, I'm going to assume means an MD and not a nurse practitioner. But, I mean, I suppose a nurse practitioner could be a general clinician. And VBA does use nurse practitioners a lot in other types of claims, especially orthopedic claims, and other neurological claims, headaches. I see nurse practitioners on those exams a lot. Unfortunately, the state of the law now is that that's A-OK. VA is allowed to use nurse practitioners. If you have a problem with it, you have to raise it to the adjudicator, which means you have to have a copy of the examination, which is not automatically provided to you as the veteran or to your advocate. Those of you who are taking, I guess, civil procedure now might be a little bit familiar with the doctrine of exhaustion of administrative remedies and the courts that have exclusive jurisdiction, the CAVC and the Federal Circuit, over VA decision-making benefits applies the doctrine of exhaustion of administrative remedies to issues such as challenging a VA examiner's competence because that person is a nurse practitioner and not a neurologist. So any of you who are involved in veterans benefits law and deal with TBI, keep an eye out for this. So, and then, since then, since 2008, we've had even more improvements. We now have a regulation that was passed, I think in 2014, that provides that veterans will automatically be provided benefits for conditions that are known to be associated with TBI. So that includes Parkinson's disease, seizures, dementia, depression, and hormone deficiency diseases. But it really depends on how severe the TBI was when diagnosed, and I'm sure we're going to get into that a little bit later. And how long from the initial TBI the secondary condition manifests. A new thing that I think was 2012 is that veterans who are severely disabled from TBI are eligible for special ancillary benefits, including TBI special monthly compensation, which a single veteran can receive as much as $8,318 a month as a result of this special compensation. But that it's only available to veterans whose TBI renders him or her in the need of aid and attendance of another, such that without that aid, the veteran would be institutionalized. So it's kind of a way for a veteran to stay out of an institution, but also have the income to be able to pay somebody to provide that level of care to him or her. So that's for the most severely disabled veterans. And those of you who read Dr. Oki's articles might have noticed that one of the veterans talked about how he was rated R1 and said that that's the most disabled that you can be. This is R2, and this came out after Dr. Oki's article, but this is another example of VA really doing the right thing and stepping up and really appreciating the level of disability that is associated with really severe TBI. Another really great program that has come out is comprehensive assistance for family caregivers. So this veteran who has the R2 veteran who would otherwise be institutionalized can stay at home, and his or her wife or other immediate family member can take care of the veteran and not have to worry about holding down a full-time job, because the VA provides a monthly stipend, training, respite care, health insurance, and other benefits to the caregiver. Now, how that program is going, I can't tell you. I don't deal with it really at all. I just kind of know about it. So I don't know if it's if it's working out the way that it's intended to. But here we have some ongoing issues that come with these great improvements that VA has made. We just kind of talked about non-qualified professionals providing TBI examinations. I've certainly seen that in my own practice, that the person providing the exam doesn't fall into one of the categories we just talked about. And there was recently a news article about that. It was in the AP, wasn't it? Yeah, so it's something that is happening. Talked a little bit about adjudicators applying the table incorrectly. Again, if we lived in a perfect world, everybody would do it perfectly. There's going to be some problems with it. But that's why we have advocates like Angela and her students who can catch this. Yeah, and then, you know, this note that is really a great thing that you can get this separate rating sometimes isn't applied appropriately, and people are getting one combined rating for TBI and PTSD or in headaches or tinnitus instead of the separate ratings. So the veterans are being shortchanged on their disability ratings. Okay, well, I think we have 5 minutes left.
And ask people to come to the microphone. Oh, here. We have 5 minutes for questions because we're going to stay on track. So if anybody has questions for Amy, please approach that microphone, or I'll hand you this microphone over here. Any questions?
Thank you very much, Amy. It was wonderful. One of the questions that I have is relating to proving up the injuries and damages. Is an advocate and their client, are they able to go out and get their independent neuropsychological test to determine their own rating and then take that to the board for their decision? Or is it always you must go to the VA adjudicator or whoever does these tests, and that is the final conclusion?
So yeah, veterans are allowed to submit their own private medical opinions. But there are problems with that, right? First of all, VHA professionals are unlikely to want to get involved with VBA business. And usually these veterans get their only care from VHA. An expert opinion from a neurologist or somebody with the required expertise in this area is going to cost thousands of dollars. And veterans often, just like pretty much all of us in this room, don't have thousands of dollars to spare on a medical report. And then even if that thousands of dollars of medical report is good and there's nothing wrong with it, VA is still allowed to go out and get another medical opinion from their own people. And if that medical opinion is negative, then you have conflicting evidence, and oftentimes it'll be denied. So yes, technically yes, but practically speaking, the veterans are left to rely pretty heavily on the VBA doctors.
Thank you. Hi, Amy.
Hi.
So whenever you're reviewing the examinations and the doctor doesn't happen to be on that list, but he is probably maybe received the training that you talked about for the TBI protocol or whatever it is, right? How do you determine if they actually received that training? You know, you can go online and look them up, but it doesn't tell you that they necessarily received that training.
That's a really good question. So the answer to that would be that you should ask for a CV or ask the VA to get information and prove that. And the veterans adjudication process, the veterans benefits adjudication process is very informal. There's no rules of civil procedure or evidence or anything like that. But there's a recent case law that says that you have every right to ask that the VA to provide information regarding the examiner at the administrative level. You have no right to do that at the court level, but you do at the administrative level, and VA has to comply with that, because otherwise, how are you going to rebut the presumption that exists that that examiner is qualified? You can't do it at court because the doctrine of exhaustion of administrative remedies applies. So you have to do it at the agency. So I would encourage all veterans advocates who deal with TBI to definitely ask for that information.
So you ask the regional office directly?
Yeah,
ask
you
the
should.
healthcare provider directly? You ask?
The regional office, because you want to quote unquote paper the file, right? You want to make sure you have documentation that you ask for this information, and then once you get it, you want to have documentation of it in the claims file.
So if you do not receive it, or if it's not right, the court would remand it to that point?
Yes, absolutely.
That's it, Amy.
Okay.
Love you.
Thank you.
Thank you. I did want to add, in the clinic we have been, there's a recent VHA directive that notifies VA treating physicians that they have the discretion and are able to help veterans fill out disability benefit questionnaires and provide medical evidence in connection with the claim. And we have been in the clinic reminding treating physicians of that directive and of their ability to do that, because VA gives a lot of really good care. And I know our veterans here in the Columbia area, they've experienced good care at our local VA and have a really good relationship with their doctors here in town at that VA. So there is a directive that would allow a VHA doctor to help the veteran with their medical evidence if necessary. Amy?
But not with TBI.
But not with TBI, okay. So I guess if it's a knee or some other issue, they can help, but not with TBI. Thank you.
TBI, PTSD, and both more undiagnosed illnesses, VBA keeps in VBA. You're not allowed to do it.
Okay, so that's important. The treating physician can help with everything except for TBI, PTSD, and Gulf War syndrome. Okay, thank you, Amy. All right, our next panel, please come on down, and student Aaron Jolly will introduce them. And now you're going to hear from some veterans and a psychologist on the issue. And we'll take a break after this panel, but again, if anybody is disturbed, because we're gonna see some video here, you may leave, and if you need to get coffee or something, feel free to move around the room carefully.
Good morning. Wow. Good morning. My name is Aaron Jolly. I'm a 2L student here, and I serve in Professor Drake's Veterans Clinic. I have a privilege to do that. I'm also distinctly privileged and honored today to be able to introduce to you our next panel. On my left here, I have Mr. Sean Lee, one of our nation's finest veterans, and Mr. Alex Proct. I'm also one of our nation's finest veterans who are going to talk to you about what it's like living with TBI. And then seated next to Mr. Proct is Mr. Proct's mother, Pat, who's going to talk to us a little bit about what it's like living with somebody who has TBI. Moderating is going to be Dr. Eric Hart over here, who's going to give us a little bit of background information before we get started with the actual panel. So thank you for being here, and enjoy.
Okay. Can you guys hear me okay? Okay, I'll try to speak up. Okay, so I'm Eric Hart. I'm a clinical associate professor for the University of Missouri. I'm also the director of the Adult Neuropsych Service on campus. Okay. I'm the immediate past president of the Brain Injury Association of Missouri, and most of my career has been devoted to assessing and treating survivors of traumatic brain injury. Primarily, I see civilian survivors of brain injury, but my service also reaches out to Fort Leonard Wood, and we also see a lot of active military who have been recently injured or have a history of possibly cumulative brain injury. So my job's easy. I have 15 minutes or less to walk you all through the behavioral neurology of traumatic brain injury. So I'm going to do the best that I can. I'm going to first what I wanted to talk about is certainly listing the types of brain injuries, but also I want to talk about what exactly a traumatic brain injury is. And a lot of times there's some confusion. Now, you all may be well versed in the literature, but it's really surprising to me how many people don't have necessarily a clear understanding as to what exactly a traumatic brain injury is. And when we're using the term trauma, we're talking about the mechanism of injury. We're not talking specifically about the psychological trauma that goes along with it, which is certainly significant. But what we're talking about is essentially, again, the mechanisms or the force being acted upon the head and causing some type of neurological consequence. And we compare this to other types of brain injury, such as acquired brain injury, the most common being stroke. So when we're talking about traumatic brain injury, again, we're talking about the mechanisms that cause the injury in the first place. So when we're talking about different types of injuries, by far the most common is closed head injury. So in this instance, there's force that acted upon the head. There is movement within the cranial vault of the brain causing neurological consequences, but the protective layers around the brain are not penetrated or lacerated. Now then we compare that with the open or penetrating head injury, which are by far less common, and that of course is an instance when there is action acted upon the head, there's actual disruption of the cranial vault, the penetration disrupts the protective layers. And of course, we're talking much more now about blast and percussive injuries. And those are most commonly seen with our military folks. This is a pretty detailed slide. I really don't want to walk through much of this. This is a coronal section of what's the contents of the cranial vault. The reason why I display this is because, as you can see, there's obviously a lot of dense area here. There's gray matter, white matter, there's blood vessels, there's protective layers, and the cranial vault is essentially fixed. If there's some increased pressure, if there's swelling, there's no place for it to go. So this obviously can lead you to conclude that when there is significant injury, when there is that causes a bleed or swelling or something along those lines, that can certainly be life-threatening and cause a whole lot of consequence. Just to walk you through some of the verbiage that you may already know, but I just wanted to reiterate some of this. When we're talking about the point of impact and the rebound effect, essentially what we're talking about is the coup and the contra coup. And the best way to really illustrate this, even though I think these pictures probably do it justice, the best example that I can give, say if I had a basketball and I were to bounce it up against that wall, it would ricochet and could hit the other wall and so on and so forth. So that implies that there's an awful lot of movement going on inside the skull when there's enough force acted upon to cause the brain to move around. So the point of impact being the coup, and then the contra coup is that diametric rebound. And sometimes that can be even more significant. And here's just sort of another illustration of that. So I want to just kind of point out here that our healthcare providers, our physicians in the room may cringe when I say this. Just sort of ignore this basal skull fracture here just for a minute. Really what I wanted to show is that there is an awful lot of, there's much less space, so to speak, for the brain to move around in the front part of the skull versus the back. And that's really important because a lot of times when I work with patients and families, they will often say, boy, this is just, it's a mystery to me. Or one of the most frustrating statements that I hear from a patient is, everybody says that I look just the same as I did before, but there's a lot of change. And then there's families that will say, I just don't understand why my loved one isn't behaving like he used to, or she, or remembering the things. He's just not paying attention. Or he's just so darn lazy, he's just not getting things going. And we can understand, if we don't understand what's going on inside of the brain, well, we can understand why people may draw those conclusions, because for the most part, again, most people who've had brain injuries, unless they have a visible trach scar, unless they have some sort of physical limitation, you very well may not know the good and the bad of the invisibility of the brain injury. We don't always want to wear our vulnerabilities on our sleeve, right? But at the same time, we also want people to understand that life is now different. And why is it different? So I put this slide up here because really one of the roles that I see as a clinician is to sort of demystify some of this phenomena that manifests after a brain injury. So bear with me here. So you notice that there is much less room up front. You have these bony irregularities in the anterior portion, where the posterior portion, again, ignore the basal skull fracture there. It's a much smoother area and there's a lot more room to move around. And the reason why that's important is because this is a really crude picture here, but I really like it because I think it illustrates what I'm about to say very nicely. The darkened areas are essentially areas of contusion or lesion or bruises in the brain. And what you notice is, if I had a pointer, I'd point it out to you, but I think this kind of does a nice job. You'll notice that this is looking up at the brain. This is the inferior surface here. Oh, ask and I shall receive. I have to figure out how to, oh, there we go. Okay. So this is looking up at the brain, and this is what's called the orbital frontal area. So it's the base of the brain, but it's the anterior portion of the frontal lobes. And then you have the side here, which is the temporal regions of the brain. So although there can be lots of areas of lesion, I think it's important to point out that by and large, and this is sort of a blanket generalized statement, almost, I say almost regardless of where the point of impact is, these areas are most vulnerable, okay? Because again, there's impact, and then there's movement of the brain, and the brain, if there's enough force, the brain is moving inside that cranial vault, and again, there's less room to move around up front, so even if you're hit on the side, or if you're hitting on the back or on the front, you're more than likely, not always, but more than likely to have injury in those areas. So there's a lot of times where patients and families will say, can you tell me where my injury was? And let's say I don't have a medical information from the physician. Let's say I don't have MRI or CT data. I can say, my guess is it's probably in those areas. And here's why that's important. Well, I spoke too soon. Let me back up a little bit. Here's why that's important. Although it's not a perfect science, there are pretty significant correlations with areas of injury and what that manifests later on. And I'm going to talk very briefly about some of those things in just a little bit. I do want to point out what's being talked about a lot, of course, is the secondary injury. So this, we're talking about a primary versus a secondary injury. The primary injury happens at the point of impact. That's because that is a result of the physics, the force that's involved. The secondary injuries are really more of the biomedical consequences. So these occur sometime after that point of impact. There's very little that can be done to prevent a primary injury, right? If you hit your head, there's very little that can be done to prevent some of those initial consequences. And I didn't say that there's nothing that can't be done, but bear with me here. The secondary injuries are identifying their occurrence is really what is saving lives. So identifying a secondary bleed, identifying some sort of swelling, edema that causes increased cranial pressure. Again, that cranial vault, the contents, the space in there is fixed. There's no space for any additional structures, fluid, what have you. Seizures, diffuse axonal injuries, identifying these early on is what can save lives. And this is why if you were to look historically at the literature on traumatic brain injury, if you look way back when, the survival rates were much lower than they are now. And the reason for that, a primary reason, is because these kinds of signs are being identified and interventions can be prescribed accordingly. So I wanted to point that out. So again, as I said, I'm a neuropsychologist, so I think a lot about the cognitive consequences or the behavioral consequences of a brain injury. Not all brain injuries are the same, most certainly. Okay, I love the saying from a pretty prominent neuropsychologist out east that says, once you've seen one brain injury, you've seen one brain injury. And that is very, very true, and I really like to say that. However, of course, because we have some degree of predictable pattern, some degree of predictable injury, we can have some idea about what's to expect, what we can expect from those areas of injury. Now, problems with attention are very, very common, and this can take many different forms. Without getting into too much detail, we're thinking about impaired vigilance, so inability to sustain your attention over time, to concentrate. Distractibility, if there's noises that are going on, you may have a difficult time maintaining your focus. And then, of course, dividing attention, so you're going between two or more things. You're trying to pay attention to what's going on in one area and then another and alternating between the two. Oops. No, let's see here. Okay. Problems with processing speed. So it may take you a little bit longer to process information. And I say that it's really difficult to identify a specific area in the brain. And really what I mean by this is there's not necessarily a structure per se that's injured and you then consequently have problems with thinking quickly. It really has to do with some of the changes in white matter. When there's an injury, there's some stretching of those axons, and the disruption of that coding of the axon can then slow down signal processing. So then you have slowed mental processing speed. Memory, this is, of course, a very common consequence that can be temporary as it occurs in post-traumatic amnesia, or it can be permanent. There can be varying levels of memory changes that go along following a brain injury. And I showed you guys that depiction of the common areas of contusion, and I referenced the temporal region of the brain. That's really one of the primary areas that's involved in learning new information, or memory for that matter. I'm not going to go into too much detail about memory. We could have a whole discussion about memory, lots of different kinds. And it's really important as a neuropsychologist that I'm trying to cover all those areas: visual, verbal, learning, recall, procedural memory, those kinds of things. Executive functioning, this is something that, I don't know why I'm clicking the pointer to advance the slide. I got to pay attention to two things at once here. I guess I'm struggling with that. I apologize. So, executive functioning. Really, when we're thinking of executive function, we're thinking of higher level cognitive processing. So this is integrating all those cognitive areas of functioning and then making sense of what to do with that information. So it's problem solving, reasoning. It can also be behavioral control. So you may notice someone who's either recently injured or has had a very severe brain injury, and you're seeing them several months to several years post. They may have a difficult time controlling their behavior. They may be inappropriate in public. They may, conversely, even have difficulties with initiating or following through with behavior. It may not be that this individual is lazy per se. They may very well want to start a task and follow through with it, but the mechanisms that allow for that behavior to play out are offline or injured. So, and then we also have some speech and language difficulties, which again can also take on many different forms. We tend not to see some of the classic aphasias that you would see with a stroke, although that can occur, no doubt about it, especially if you have a very circumscribed lesion in the brain. But what we really see play out more commonly is difficulties with organizing thought. So when talking with someone who's had a brain injury, a very significant one, you may notice that their thoughts are disorganized, or the receptive language abilities are not what they used to be. You can also have a scenario where the right hemisphere of the brain is affected and someone may not understand humor or social pragmatics the way that they used to. So you can see some social change in that regard. And of course, psychiatric consequences are very, very common. There's some really interesting literature that I'd like to share with my trainees. We talk about, well, and I love pointing out this slide, you know, neuropsychologists and psychologists are very specific, and we really like to be definitive in what we say. And of course, you see the literature, the literature that talks about the prevalence of depression in a TBI population, you see between 6 and 77%. That's a really helpful statistic, isn't it? So it may not happen at all, or it happens all the time. So I basically, just sort of tongue-in-cheek, I wanted to throw that in there. But really, what we're seeing is probably in the order of about 42 to 45% of those that have had a traumatic brain injury may experience some type of mood disorder. Okay, and that is actually about double the normal neurologically intact population. So what we're seeing is brain injury can certainly cause depression, even if there's not depression to begin with. And there's a number of reasons for that, and a lot of that has to do with the time frame in which those symptoms develop. Certainly there's a whole neurochemical cascade that can begin after the brain that is injured. Well, that can certainly result in what used to be called an organic depression. Your neurochemistry is unbalanced and you have a mood reaction. And then you can also have, sort of later on down the line, the adjustment depression that is commonly seen. So in other words, you have an injury, it's limiting you from doing the things that you enjoy doing. You're not able to return to play, you're not able to return to work. You have maybe physical limitations. You're frustrated because family doesn't understand you the way that they used to, and you can have a reactive depression. You're allowed to have both, though, keep in mind. You can certainly have the more chemical-based depression and a reactive depression, no doubt about it. There are some important differentials, if you will. A lot of times we can see folks, especially if they've had frontal lobe injuries, that may be sort of apathetic or indifferent, or have difficulties initiating, or may have sort of a masked facial expression, or they may have what's being talked about a lot now is the pseudobulbar affect, where they have uncontrollable tears, or they may even have uncontrollable laughter, and it's incongruent to their mood state. So in other words, you may have somebody that's very tearful, but they very well may not be sad, and that's very frustrating for both the survivor and the family. But anyway, there are lots of different things that can mimic depression. So if someone isn't initiating and following through with things, and they seem flat or apathetic, of course our conclusion is, my goodness, they must have depression. Well, maybe or maybe not. Maybe we need to manage things a little bit differently. Maybe it's not a course of psychotherapy that they need. They really need some environmental management, some prompts to allow them to get going, to help them follow through with the activities that they really want to pursue. Just a couple more. I want to kind of run through this. Okay, so we want to get to anxiety. Neuroanatomically, anxiety is often associated with injuries to the right side of the brain versus depression, which is sometimes associated with the left side of the brain. That's not an exact science. There you will find literature that suggests that and others that contradict. Remember, we're very definitive and conclusive in what we do, right? And I just wanted to throw in some of the prevalence rates for different types of anxiety conditions. So generalized anxiety disorder, about 8 to 24% in the brain injured population, up to 0 to 42% of those experience some degree of post-traumatic amnesia. And what's important to point out that a lot of the studies look at brain injury as sort of an aggregate. So you were including both mild, moderate, and severe brain injury. So sometimes you'll have patients who have no loss of consciousness other than an alteration of consciousness. So in other words, they very well may remember that traumatizing event. So then therefore that puts them at risk for having a post-traumatic stress response. Now you don't, yeah.
Slide says PTSD is 0 to 42. Is it post-traumatic amnesia that's 0 to 42?
No, post-traumatic stress disorder. A post-traumatic stress response, it was the verbiage that I was using. So you can have complete amnesia of the event, so you don't have that recollection of traumatizing experience, and that very well may buffer you from reliving that. You very well may have full recall of everything that happened, and 1 minute your life was one way and the next minute it was very, very different. So we can see how psychologically that can be traumatizing. I will say though, you can have post-traumatic stress disorder even with no recollection of the event, because there's a lot of things along the course of recovery, and especially acute and post-acute care, that can be very psychologically traumatizing. You can also have a scenario where the brain is filling in the blanks, if you will, and there is a created memory of what happened. This is you can imagine how psychologically disturbing it would be to know that you don't have memory of something that was very, very important in your life. And we think about that, it's very difficult for those that haven't had a brain injury. That's very, very difficult to wrap your mind around, if you will. Okay, and I just threw this in there, psychosis, thought disorder. The bottom line is you don't see schizophrenia that comes up after brain injury. Okay, so it is not very common. Typically what happens when someone has a brain injury, they may have misperceptions of reality. They may have unusual sensory experiences. They may have disorganized thought. That is not necessarily a major psychosis. It's related to the changes that are going on in the brain, okay? So it doesn't put you at risk for schizophrenia or things along those lines. Okay, so I just want to finish up here. So, you know, this is not an exhaustive list, but I just wanted to point out that because of all the consequences of brain injury, now keep in mind, within the short period of time, I really just touched upon what my bias is. Okay, so I'm talking about the cognitive and emotional piece. That's what I see and that's what I deal with. Most certainly, there are lots of other consequences: physical, speech, respiratory, different nursing needs, case management. So really, this requires a very comprehensive, and I say interdisciplinary, not multidisciplinary, interdisciplinary, meaning that the treatment providers are working together. So, you know, treatment can take on many different forms. It can be all or some of these interventions. This brain injury doesn't just affect one person, it affects a whole system of folks. From partners, loved ones, work colleagues, and so on and so forth. So outpatient comprehensive rehab, inpatient, outpatient rehab, home health, psychopharmacy, neuropharmacy, rehab psych interventions, individual, family, marital therapy. This is not a one-size-fits-all, and I want to leave you with a phrase that I really like to share with my trainees because I think this makes a whole lot of sense. We're talking about a lot of the commonalities of brain injury, and we talked about a lot of what happened to the brain, but it's really important when you're tailoring a treatment or understanding someone who's had a brain injury, it's also important to understand the brain that it happened to, if you will. And that sounds like I'm sort of playing with words here, but all these things can take on many different forms depending on who the person is to begin with and the system in which they exist. So we cannot assume one size fits all. So with that said, I'm going to be quiet and turn things over to our panel.
Yeah, let's let Alex talk. You want to start with the video, Alex, or do you want to? Are you mic'd up? It's Alex Prock, can you hear him, Aaron?
Just so you guys know, this video is pretty graphic. You know, we serve some of you folks. I'm not offended at all if you guys have to step out or anything like that. I'm going to give you an introduction to this video.
I don't think your mic's on, Alex.
Okay.
Hello.
Test. Hello. Hello, 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 hello. Alex Proct. I love him like a son.
You're like a mom. Anyway, a little introduction to this video. You can read it here. It happened June 19, 2009 in Kandahar, Afghanistan. We were in a very large convoy carrying newly graduated Afghan National Army and Afghan National Police and escorting them basically through Kandahar, and it would be a 4-hour trip into Helmand province. Well, we didn't get just outside the city, and you'll see why. The amount of explosives that they estimated that explosion was 750 pounds of explosives.
Look forward.
And you can take note that this is definitely a 2-lane highway, basically like an interstate type deal, with 2 lanes on both sides. Then this crater that you're about to see will give you a perspective of just how big this mountain is. And that's my vehicle right there. Another perspective, this vehicle weighs 9 tons, and the explosives shot us 30 to 40 feet in the air. Right now they're working on my best friend, Josh Melton. I don't look very good in a mustache. Anyway, I wanted to share that just so you guys get an idea of what daily life is in a war zone. That does happen to someone every day. And a lot of people get killed. And sorry, that video is still kind of hard for me to watch. But basically today, what I want to drive home is kind of get more awareness out to the public of what our troops are doing overseas and what we go through. My injuries in that explosion, had traumatic brain injury, collapsed lung, some internal bleeding. But the major injuries I suffered, I actually had all of my lumbar spine broke. All 5. I had 4 of them that were compression fractures, and 1 of them that was a burst fracture that basically destroyed the entire body of the spine. The miracle of this situation is that, as you can see, I'm standing. I was actually being yanked on to try to get removed from the vehicle, extracted from the vehicle, with obviously not knowing that I had the spinal injury. So at any point in time, that could have been it, and I'd be in a wheelchair today. Sorry. I was flown from the scene to Kandahar Airfield, briefly treated there just to get stabilized. Was flown to Landstuhl, Germany, to their Trauma 1 hospital. They assessed me and very quickly decided that my case was entirely too complex for them to work there. So I was flown to Walter Reed Army Medical Center in Washington, D.C. And I had surgery 4 days after the initial injury. When he talked about the post-traumatic amnesia. I don't remember the first or the last few minutes up to the blast. I was knocked unconscious, and I don't remember anything except for small bits and pieces right at the scene and right after the scene at the hospital. And the next thing I know, I wake up and it's 3 weeks later. That's the next thing I know. Don't know how I got to Walter Reed, don't know what happened, you know. So it all came at a big surprise to me. But, you know, the general public needs to know that this type of stuff happens, and need to push to get that awareness out to more of the general public itself. I don't know where to go from here. Yeah, Sean, you want to talk a little bit? Yeah, she can. This is my mother, Pat Proct. She'll talk a little bit about she's going to talk a little bit about what it's like living with me.
You really don't want to go there. I was with, we were flown to Walter Reed when he got there. And of course, he doesn't remember anything because he was so high on drugs that, but he was aware and thought they were going to cut his leg off. And you're trying to tell him that's not going to happen. That's not what's wrong with you. And he thought about his best friend, Josh, and that why did I live? He's got a wife, he's got a job, he has a family. I don't have a job. I don't have, I'm just me. And I told him it's God's will. And I truly believe that. And he was easier to deal with kind of in Walter Reed than he was when he came home. I stayed for a month with him in a housing thing they have for the veterans there. And it's hard to see him cry because he couldn't get his socks on, couldn't get his shoes on. Had to help him get dressed and whatever else. And when he came home, he's just different. His memory's not as sharp as it used to be. I have to watch the mood every day. When he gets up and we first start a conversation, are you gonna rip me one or are you gonna be nice to me? And when he decides he's gonna cuss me and whatever else for just a question I ask him, I just put my hand up and I leave him. I just go away from him because we could have a major conflict. Otherwise, on a good day, he's fine. He lives with us, has his own room, and that's where you find him most of the time. He used to be very social, not anymore. He first came home, when we go to a restaurant, he'd watch everybody. Is somebody in here gonna kill me? Is somebody gonna attack us? And whatever else, and he'd wanna go home. Home is his security. His room is his haven. And whatever else. And I've seen him go through many things there. Josh's wife told him that he should have died, and she hates him. He's had to deal with that, and that brought on lots of depression. I'm glad that he's here today. I am totally surprised that he's walking, because the part of the video you didn't see was them pulling him out of that truck. And with a broken back, he could have been paralyzed, whatever else. He is on so many medicines. I can fill a shoebox. For depression, for pain, to go to sleep, and a number of other things. He is seeing a psychiatrist, which is, I think, going to help him. But it took 6 years for him to finally decide, I need to see somebody. And even though we would suggest it, don't go there. There's nothing wrong with me. He'd just as soon defy you as he would agree with you. And that wasn't him. And he went to college and had almost a photographic memory. It's gone. He doesn't have it anymore. So I can just tell you that as his mother and his father, we just have to gauge it day by day. We can't look a month ahead of time. We know what's behind us, but you don't know except for day by day. So it does affect them all that come home from there. And it's something that they will never, ever forget. And it does affect the families. So there you have it.
Thank you, Pat. And I urge everyone to look at Alex's bio on the website. He's one of our heroes. When you look at his DD-214, he has so many medals and commendations that it goes on to the next page. I mean, he was a remarkable soldier, and we thank you for your service. Sean?
One more hand for the mothers that put up with us out there. I would think my mother would echo all of those answers, and I don't thank her nearly often enough for putting up with me. I'm going to talk to you about some of the things that I feel like you all should know from an advocate's standpoint. Some of you are going to go out there and you're going to interact with some of these folks, whether it be through veterans courts or through your various programs you're involved with. And I'm going to tell you a little bit about my story so you kind of understand what some of this looks like. What I was like before the bomb, I considered myself an academic. Whenever I was in Baghdad, I came up with a list of all of the novels I felt like I needed to read to be educated. I was taking online courses through University of Maryland, and I generally had a pretty decent military career and had simultaneous applications in for Officer Candidate School and Special Forces. I was promoted the day that I deployed because people felt like they could trust me with responsibility. I was out on a routine mission the day of the bomb, and it was kind of a toe popper. Do I have a slide here I'm supposed to show? Okay. So I was out on a mission. We were going to talk to a village elder. I was taking point in the vehicle. All of a sudden we found ourselves in the air. Did not mean to hit that IED. Looking back, wish we hadn't, but we did. Vehicle was thrown in the air. The driver somehow landed it because it bounced several times. We got out, pulled security. Some of my crew were having headaches. They were throwing up, real sick to themselves. I had a lot of adrenaline going. I was trying to call onto the radio to look for the trigger man up in the mountains, like 2 miles away. So a little disoriented. The trigger man was actually off to our left in the village we were there. We didn't know a lot about TBI at the time, so we continued the mission. Doc went around, asked us how we were feeling, said, fine, let's keep going, let's show them that they cannot get us down with a little toe popper IED. We continued, spent 4 hours out in the 130-degree sun talking to village elders in front of the IED strike. My guys started to show a lot of the symptoms right there. They started getting real sick, real disoriented, they couldn't hear very well, a lot of tinnitus, back pain. I didn't realize I had a TBI for about 4 months. About 4 months later, I started feeling like I was having an aura, and then I woke up in a helicopter screaming. They were telling me to calm down. I woke up again at Bagram Airfield, and I had a grand mal seizure. I was evacuated to Landstuhl, Germany, and I still didn't know I had a TBI. They just thought I had a seizure disorder, and there was not actually any real damage. And that's when things started to not click. I wanted to go calm down, so I called up a buddy of mine, went out to eat, went into a local bookstore there, picked up a magazine or two, and sat down and started trying to read the magazines. And I realized I really couldn't read. like I could understand the words on the page, but I couldn't link them together into any sort of understanding. And this really upset me. I had been a person that devoured books before that. And now all of a sudden my passion for reading was deprived from me. And I still didn't know I had a TBI. So I left the bookstore, I went outside, somebody said something to me, and it just set me off. And so I started going after this guy. Not hitting him, just screaming at him, screaming mostly gibberish. Somebody pulled me back away from him, and then I sat down on a concrete pillar and just started crying. This is all out of character for me. I was not this violent person prone to emotional disturbances and crying. I had responsibility, I was an academic, I had a career that I valued that was based on discipline. All of that was out the window. After that, somebody finally evaluated me and said, "Were you in an IED strike?" I said, "Yes." And so they sent me for a neuropsychological evaluation and a CT scan and found out I had a number of lesions on my brain and that I did have a TBI. The process involving that was horrendous and something that I want to emphasize out there because you're going to run into these things. They did not immediately recognize you have a TBI. That's not how this process looks. They don't say, "Oh, you were in an IED strike, let's get you taken care of." Typically, it looks like misconduct. And this is an environment that prides itself on discipline. So for a while, I was ostracized. For a little while, they tried to deny my condition. At one point, they had me on medication that caused seizures. And so I had a number of seizures in hospitals. At one point, they accidentally put me in a coma. And when I came out of the coma, they told me that I had faked the coma. Finally, I had a seizure in my commander's arms, and he wrote a memorandum to the hospital command team that says, "You will treat him for TBI and the seizure disorder." The military's catching on. Now they are starting to treat people, they evaluate people, but back in the early years of the war, we didn't know to expect all this. We didn't know all these guys were going to come back and have these problems with misconduct, with memory, with discipline. We're catching up now, but at the time, people suffered from it. I got into a rehabilitation program. I was there for about 6 months, occupational, speech, physical, and then psychological as well. And that is why I am wearing a suit today and I have a law degree, because I was able to go through that program. It is important to note that no one else that was in the vehicle with me that day got to go to that program. No one else got a Purple Heart. No one else got a proper evaluation. No one else got rehabilitation. I can tell you right now that several of them got other than honorable discharges for misconduct. One of them is actively abusing drugs and alcohol, despite many of our best efforts. And all of them have various forms of pain relating to brain injury or the physical symptoms of being blown up. We're trying to catch up for those guys, but they're out there. And I believe the statistic that I'm a part of right now, the 1 guy out of 5 that got treated, I think that can be applied to a majority of the IED strikes and the people that were in our military. How it affects me now? Well, I'm looking at notes because I cannot just run off memory. I cannot just put something together the day before, have it memorized, keep myself into a 15-minute window, and then deliver it professionally. I have to set up these systems for myself. I've been described as a person who has ideas but doesn't finish things. That is very common for me to come up with something, get about halfway through it, and lose track. So I have to calendar ahead 30 days on all things that I'm going to do. Not just the health issues, but professionally it's an issue. You can't just put, "I have TBI and PTSD" on an application when you're trying to get a job places. When your job is communication, professionalism, and not making mistakes, you can't throw out there that you're currently disabled. Disability discrimination is a real thing. I have some outstanding employers right now who understand my condition and work with me on it. But There are a lot of employees out there who specifically avoid people that they know may have disabling conditions like this. I may not make as much as some people that, or as whether if I had not had a brain injury. Socially, I have issues. Making and keeping friends can be a problem. Being able to respond appropriately in conversations. I think a few of you who probably went to law school with me can think of a time or two when I said something that was inappropriate. Yeah. Let's see. There's a couple giggles up there, I know. A time or two. Yeah, time or 3. Yes. Hasn't happened today yet, though, but I'm only 9 minutes in. What we need to do, we need you all to leave this room and do something, okay? There's some attorneys, there's some advocates, there's people who are going to be attorneys, and there's people just watching. If you're attorneys, go out there and pick up a case. Go to the vet court and say, hey, I'm willing to help somebody with that. Maybe not with a criminal issue, but you can say, hey, I'd like to talk to you about whether or not you've had a proper disability evaluation. Have you applied for Social Security? Okay? Because you have knowledge that they don't. We got to find these people. We got to find these people on their behalf. They're not just going to come in and say, hey, by the way, I was in an IED strike. I feel disabled. Can you check to make sure that I'm disabled? No, they're going to manifest in symptoms that you're going to run into in your legal profession. They're going to get in trouble. They're going to be drunks. They're going to be degenerates. They're going to have issues that relate to not being a functional member of society and making decisions that aren't always appropriate.
Sean, do you want to show your evaluations or not?
Yeah, go for it. So this was my evaluation. I had to go through 6 months worth of regular evaluations, and I would have to take these little tests. You know, your little cell phone games. I basically played little cell phone games, and they gauged how accurate and how quick I was. These are my accuracy scores. If I was playing, say, Bejeweled, I could accurately play the game. I could accurately line up 3 things that matched. I couldn't do it very fast. Notice this is the normal range up here, and here I am down here around 40 and 50%. So quickness and being able to make decisions in a timely manner were a real problem for me initially. Working on it now, but let's see. But what's some other things that you can do? Some of you may not be able to take cases, but you can write. You're looking for journal article ideas? Well, this is an area of law where you can make a big difference because it's emerging. We didn't know 15 years ago that we were going to have 300,000 brain injuries on our hands. We didn't know years ago that we were going to have several million people with a new psychological disorder called PTSD. I mean, it was somewhat known beforehand, but this is our first time having our national economy handle such a magnificent load of disabled people. So, you can write about it. Go out there and share something on social media. A lot of you have 700, 800 friends. You're influential. Look up an article on TBI and share it. And that way some people know about it out there. And if they see a guy who is out there in the street screaming at somebody inappropriately, they can say, hey, were you in an IED strike? Let's get you down someplace and evaluate it. Leave this room and do something, okay? Please, because people need help. They are not going to save themselves. A lot of you got into this profession, you want to help people. This is a population that needs it. People are dying. We are still taking casualties overseas, and we're still taking casualties here because we don't properly treat the casualties we take overseas. So, thank you.
Use the rest of our time to answer questions, if anyone has anything they'd like to ask our panel.
diagnose if someone has had a traumatic brain injury, even if it was maybe 10 or 15, 20 years later? Is there evidence in the brain that would still show trauma?
Well, certainly it becomes more difficult over time. The diagnosis becomes a little less reliable at that point. What I would do in that circumstance, which I've actually been faced with on a number of times, certainly I'm going to look into the history. I'm going to get an understanding as to what happened. I'm going to look for some type of pattern, some predictable pattern on a neuropsych measure, and try to rule out any other potential causes for why someone is having this particular pattern of difficulty. That being said, we can come to some type of conclusion. Was this a brain injury? How significant was it, and what to expect? You know, it's an interesting question to bring up because our test data does become a little bit more reliable over time, though, still within that window of recovery. So 10 years later is a little bit different than, say, maybe 6 months to a year later. I'm a little bit more tentative in not diagnosing someone with a brain injury, but coming to real specific, definitive conclusions early on, because there's a lot of room for improvement and a lot of room for change. There's a lot of change that is seen within the first few weeks, up to 6 months, up to a year. So there will be times if someone is referred for a neuropsych evaluation and they're still in those early stages of healing, my concern is their functioning may look very different by the time I even get the data back. So I may want to hold off for a little while. So timing is a very important consideration clinically. But yeah, when we're thinking many, many years post, we really have to delve very deeply into the story, if you will, and hear about some of the things that are still affecting this individual at this point and come to our best conclusions. I'm going to do my best Phil Donahue here. I'm going to walk around and pass the mic.
Thank you. My question is essentially, is there a difference in the clinical and pharmacological treatment of individuals who have anxiety and depression disorder who have had TBI as opposed to those who have not?
You know, that's a very good question, and I will most likely defer to some of our physicians in the room a little bit later on. But what I hear very frequently is start low and go slow with medications. There's not different medications necessarily that are used to treat anxiety within the context of a brain injury versus outside of a brain injury. There are certain medications, though, that have a more significant side effect profile that you want to avoid with someone who is having problems with concentration and fatigue to begin with. So there does seem to be certain antidepressants, certain anxiety medications that are more of the go-to for someone who's had a brain injury rather than not. So that's a good question. Oh boy.
Want me to speak out?
You know, I think I can.
Just wondering what kind of accommodations do you think are helpful for you in the workplace or with friends or theaters or just moving around in life? What kind of accommodations do you think would be most helpful for you?
Honesty and leeway. If I am acting wrong, don't just sit back and just think, oh, you know, I'm going to be silent about this because I don't approve of it. No, say, hey, man, no, I don't appreciate that. Well, I can acknowledge that I might be wrong, but I don't always know that I'm being wrong. If somebody with a normal social understanding doesn't say, hey, it's probably not a good idea to make that joke.
My question's for Pat.
Yes.
Having someone with traumatic brain injury in the house, what kind of, and now that time's gone by, what kind of tools or assistance would you have liked to have to help prepare you for living in this house?
I guess really a true understanding of what post-traumatic stress syndrome was and the brain injury. What should I do? What shouldn't I do? You know, I don't want to set him off, so what should I, you know, he would come home and watch war videos over and over and over. You know, and I said to him, how can you do this? You were in a war, you were hurt. And then Alex had to spend 6 weeks in Louisville because he was just off the wall. And when I went there, I asked the man there, I said, you know, he watches this. He said, let him watch it. Maybe he needs to see it, you know, and whatever else, you know. As a mother, I had to ask a lot of questions. And then I had to react, of course, to what he was doing. You know, he'll tell me, just leave it alone, Mom. And I know, leave it alone. And whatever else. And it's like I told you, it just depends on his moods. And I can tell you at the beginning of the day whether we're going to have a good day or we're going to have a bad day. Just in a short conversation. And he doesn't remember. You know, I mean, he might tell me to F off, and I'll go, okay, and I go and outside or whatever else, pretty soon he hunts me down and starts a conversation. And he said, well, you're not talking to me. And I said, do you know why? Do you remember what you said to me? I'm your mother. I've been through this whole thing with you. No, I don't. And so we start again. It's an everyday thing.
This is for Sean. I'm a Mizzou grad, brother. In competitive education settings like medical school and law school, did you, and if you did, get any accommodations because of your processing speed? And if you didn't, do you think you should have given accommodations? And do you get any blowback like that's not fair in a competitive environment to get additional time for testing or anything?
No, Mizzou and especially Mizzou Law were extraordinarily accommodating. They set the example for being a good school to disabled vets. I, number one, had time and a half on tests. And that was, I couldn't be an attorney if that had happened. Because I cannot sit there and read for 4 hours and digest information for 4 hours straight at the same speed. I read a question, then I'm off over here for like 15 minutes. It's a question about, you know, divvying up who owns a farmhouse, and all of a sudden I'm over here thinking about farms that I like, you know. And so they work that time into testing for me so that I can go off over here for a minute, then come back. Oh, the legal answer to that is this. I also used a service dog during law school. That was primarily for treatment of PTSD and seizure disorder. And people were extraordinarily welcoming to that. So I believe because I was up front and said that I had some of these conditions, that people knew at the outset, okay, this guy's going to be a little different, and we're going to work with him on it.
This question is for Alex, but any of you might also want to answer it. But I guess I was curious if you feel that you're getting the resources and tools you need now to move forward, and if not, what tools do you think you might still need?
It's still ongoing. Like she described it, I've basically been in denial about a lot of things and getting treatment. I'm now just recently started seeing a psychiatrist again for PTSD, and it's a start. It's starting to help. I think me just reaching out to other resources, could be VA, it could be private, either way, just general resources that I can reach out to will definitely help me through to my next step.
And we can thank Angela for that.
Yes.
She got us started on the right track.
Somewhat. Yeah. You and I have had a lot of talks about this particular thing, and one of the things I did, I got accommodations too while I was going through law school. I had time and a half, and I could take my test in a quiet room. And I'm a solo practitioner, and essentially what I do is I do my law stuff in my basement with earplugs in, where nobody can bother me, and that's my career. And I'm productive there, and I don't go as fast as you do. But my question for you is, as you talk to other vets that are, our group that have got these issues, are you steering them towards careers and life situations that are compatible with sort of living with the disability?
I'm steering them towards challenging themselves. Too many guys I know, they focus on the fact that they're disabled and fail to remember that they still have potential. I have failed quite often. I'm very used to failure. I don't do a good job at a lot of things that I do, but so long as you can embrace that and keep moving forward, knowing you're not going to be the best at it, you can get some achievements. And I think that the generation that we have right now is we have to get them back into the job market because they are our leaders. They have experience overseas. This policy we think about back here, they're the ones over there with the experience doing it. They have the experience navigating the disability process. They have the experience with navigating the process to try and get any sort of health care. And so I try and push these guys to do more and not just settle for a job that caters to their disability, but to try and get them to use their knowledge to help the next generation.
As a spouse of a Vietnam-era veteran and sister-in-law of a Iraq War veteran, as you've already discussed, sometimes it's difficult for the veteran themselves to admit that they have a problem. Do you have recommendations for family members for a way to, I'll use the phrase, rat them out to their VA doctors or other healthcare providers, so that maybe they can be introduced to options that they might have that they don't know about because they're not yet able to admit that they have a problem?
I would pitch it to them like this, and that's that they're going to be better at what they're doing for it. We don't naturally go to the doctor. We're not people who naturally say something's hurting, I can't go forward. By definition, we're the guys who get hit and go forward. And so say, look, if you get help, you're going to be better at what you're doing. If you go get this help, you're going to be able to do a better job at your job. You're going to have more friends. You're going to have more, just try and convince them it's a great idea. And maybe they'll go into this now.
I think doctors also need to be more educated, because I mean, these are the men that are coming home, and they'll go to their regular doctor who has not a clue of what this is. And I mean, I don't know how to go about that, but I honestly believe that they need to be educated as to how to handle somebody with a brain injury or PTSD. You know, here's a pill that'll put you to sleep. Here's a pill that'll help you with your depression. Here's a pill that will help you with your pain. And they don't have the whole picture.
That's kind of how the VA treated me initially. Kind of just drugs, and more drugs, and see how you turn out. Then I've said it more very long. So I went to private position, but again, the education to look for some of the warning symptoms of these different PTSD, TBI, stuff like that. It's not they're read into.
Do the last one, Eric.
I think you both noted that the culture of the military is, as you said, you got to keep on going. So I guess I'm curious, you said they're getting better about recognizing the issues that one has to face in your circumstances, but all the men in your situation didn't get treatment, as you noted. Are they going home without knowing they might have problems?
Now, there's a lot of awareness out there, they have a lot of briefings, but, 4 years ago, at the height of the war, we didn't know. And so these guys are probably discharged now, they have all these symptoms. They might be starting to hear about this in the media, kind of putting two and two together, but they don't know how to go about getting help, how to process their claim, or even whether they actually have the issues that they're talking about. For a lot of these guys, they blame themselves. They think, I'm just a terrible person. And so half of what you're struggling with is getting them to understand that this isn't just you being a bad guy or being somebody who's not good or good at your job anymore. You actually have something that we can diagnose as being a problem.
Okay, thank you. Thank you. Please come back at 10:31 for the NFL. 10:31. Test, test, test. It's 10:34. Everybody sit down. You're not going to want to miss any of this next panel. We want to give them plenty of time. Sit down, be quiet. Quit acting like law students.
Am I on the mic right now? All right, everyone, welcome back. I hope that so far you've enjoyed the symposium and found it very informative. So my name is Justin Trueblood. I am the president of the Mizzou Sports Law Society, and I want to start off by telling all the veterans in the room, thank you and happy Veterans Day. So we've talked a little bit about how TBI is affecting the lives of our veterans. Well, it turns out that it is a big deal for some of our athletes as well, particularly those that play contact sports such as football and hockey. So we have 3 speakers here today that can provide a little more information on how these injuries are affecting our athletes and the current litigation that is going on in hopes of providing support for our athletes. First, we have Paul Anderson. Paul is a UMKC School of Law grad from 2012. While in his 3rd year of law school, Paul created NFLConcussionLitigation.com, which is commonly known as the go-to source for information regarding the current lawsuits against the NFL. Currently, Paul works at Clayman Law Firm in Kansas City, where he currently represents several former NFL players in lawsuits against the NFL, along with the Kansas City Chiefs and Arizona Cardinals. Next, we have Marvin Washington. Marvin is a retired NFL player that played 11 seasons with the New York Jets, the Denver Broncos, and the San Francisco 49ers. Marvin is a member of the 1998 Super Bowl champion Denver Broncos. It's not often we have a Super Bowl champ in the law school. He currently works for William Small Wealth Management Group as a financial advisor, primarily serving a select number of professional athletes in the NFL and NBA. Marvin has experienced a concussion or 2 in his day, and I look forward to hearing his perspective from a former player on this matter. Last but not least, we have our very own Professor Doug Abrams. Professor Abrams coached youth hockey for more than 40 years, and in 2013, he became the first lawyer to receive the Excellence in Safety Award presented by USA Hockey, the sport's national governing body. He serves on the board of directors of the Moms Team Institute, a leading youth sports health and safety advocate heavily involved in concussion prevention and care. So we're going to set the tone of this discussion by showing the trailer for the upcoming movie Concussion. Concussion stars Will Smith portraying a forensic pathologist who discovers CTE, a disease that causes brain trauma for football players. It's a true story, and it's sure to ruffle a few feathers in the NFL office. So let's check it out. Might go to the sound.
When I was a boy, heaven was here, and America was here. You could be anything, you could do anything. I am the wrong person to have discovered this.
If you don't speak for them, who will?
I found a disease that no one has ever seen. Repetitive head trauma chokes the brain.
The NFL does not want to talk to you. You turned on the lights and gave their biggest boogeyman a name.
You're going to war with a corporation that owns a day of the week.
No proof was presented today because there simply isn't any.
They have to listen to us. This is bigger than they are.
What do you think they're doing to you now? That's nothing. You have no idea how bad this could get.
I have to keep going.
They want you to say you made it all up.
If they continue to deny my work, men continue to die.
Sometimes in life, you're asked to leave it alone. But sometimes you can't.
Who are you? Tell the truth. Tell the truth.
Thank you, Justin. Guys, thank you so much for being here today. I just want to start by, again, thanking all of our veterans for their courageous service, their countless sacrifices that they've made for us. And of course, without their will to fight and protecting our country, we wouldn't be able to be here today and have these important discussions. And we must remember that, you know, it is Veterans Day, but this shouldn't just be a one-day thank you. It should be an everyday. And so again, we thank you guys so much for what you've done and for sharing your stories. Secondly, I'd like to thank Professor Drake and the Veterans Clinic for having us here. This is such an important discussion we must have. If we want football to survive, we must first acknowledge and admit that there are real dangers to this game, and rule changes must be put in place if we want this game to survive. As a young plaintiff's lawyer in Kansas City, Missouri, I had the opportunity while I was in law school to start a website called NFLconcussionlitigation.com. And it was right around whenever the first lawsuit was being filed against the NFL. And so I figured I'd spend a little time talking about the background of how the NFL concussion litigation came together. And as you'll see in this movie, it comes out Christmas Day. In Concussion, it's a true story about Dr. Bennet Omalu, the one who first identified CTE in a former football player. So how many people in here have heard the acronym CTE? That's good. That's a pretty large showing. And CTE, it's although you know the science is vastly emerging, and many academics would say that it's still in its infancy, which it is. We've known about CTE since 1928 with Harrison Martland, and it was first identified in boxers. And you look at boxing as a sport, well, of course, you know, repetitive head trauma over and over again, in which the purpose of that sport is to inflict a concussion on your opponent. It's not much different, though, whenever you look at football, which football involves repetitive head trauma over and over and over again. Studies show that it's likely that players are subjected to more than 1,000 subconcussive hits in a season. So simple rules such as limiting contact practice, ensuring that the young tykes that choose to play the game or whose parents allow them to play the game, that contact is limited. And we'll have a discussion probably later on this afternoon about whether that's good for society or not. But what Dr. Omalu did in 2002, 2004 is he diagnosed CTE in Mike Webster. Iron Mike was his name, Hall of Famer for the Steelers and played his last years with Kansas City Chiefs. And when Dr. Omalu, he's from Nigeria, whenever he didn't have any understanding of what football was. He thought it was a barbaric sport where you have these massive men crashing into each other, and he couldn't figure out why anybody would play a sport like that. So you talk about an outside, independent individual who didn't have any skin in the game. And his job was, as a neuropathologist, was to examine this brain. And what he saw was unlike any other disease he'd seen before. It wasn't like dementia, it wasn't Alzheimer's, but rather it was what he termed chronic traumatic encephalopathy, CTE. And the common thread in CTE is repetitive head trauma. Repetitive head trauma is the cause of CTE. And why it took Dr. Omalu in 2002 to bring this to the forefront is really what's at the heart of our litigation against the Kansas City Chiefs and the Arizona Cardinals and the NFL. And what you'll see in the movie Concussion and the reality and the allegations that we've put in the complaint and what we've discovered thus far is that the NFL was a lot like the tobacco industry. They pulled a page right out of the tobacco industry, where they went so far as denying the link between repetitive head trauma and later life cognitive decline. They went so far as creating a committee in 1994 called the Mild Traumatic Brain Injury Committee. And this committee was headed up by a rheumatologist. That's somebody that deals with knees and joints. And the committee is called the Mild Traumatic Brain Injury Committee. So right there you think, oh, that sounds like a red flag. And they put a few other scientists together on the committee, and they spent the next 15 years creating studies that flat out refuted the link between repetitive head trauma and later life cognitive decline. So Marvin will tell you, I mean, he's lived through the League of Denial, and he'll tell you how the policies of get back out there, it's just a ding, continue to play, how that has been destructive to his later life. So this committee published several studies in a prestigious literature, and again, they just flat out denied it. And it wasn't until 2009 that Congress got involved. And I remember whenever I was in undergrad, I would always think, why does Congress have to get involved with sports issues? Don't they have other things to consider? And looking back on that, I think that was a very misguided opinion. Of course, we as law students and academics, we understand why Congress can get involved, because it, of course, affects commerce. And you look at the NFL as one of the biggest industries in America, if not in the world. But when Congress got involved, they brought Roger Goodell in, and there's some great clips on YouTube, and it's probably in the Concussion movie, and several other members of the Mild Traumatic Brain Injury Committee. And they played a piece from HBO Real Sports Clip where they had Dr. Ira Kassin, who is also a member of this Mild Traumatic Brain Injury Committee. And he was asked 6 times directly, is there any link between repetitive head trauma and later life cognitive decline? Is there any link between repetitive head trauma and dementia? And every time he said flat out, no. And so those were the policies that were being developed within the NFL, telling the players who would leave the league after they retired, and they were starting to have this invisible injury that we discussed earlier of depression, mood and behavioral issues, and they couldn't figure out what was going on. Instead, they were told that, look, that's genetics, that's due to your steroid use, some other alternative causes. It's not related to football. And but you take a step back, well, what do you expect? You hit your head over and over again. Wouldn't you think that that's going to cause some issues later in life? Sure, you do. We think that now, but whenever you have someone telling you, no, that's not the case, it kind of puts you in a state of confusion. And fortunately, Dr. Malu, although he was ostracized over and over and over again, finally, many scientists within the medical community said, no, this is a real disease, and we've known about it for a long time. So since that date, and then shortly thereafter, after that congressional hearing, in 2011, the first lawsuit was filed against the NFL that made those allegations that players were dying at very early ages, whether it was related to suicide or some other issues, and they were being diagnosed post-mortem with CTE. And that's one thing about CTE. Currently, it can only be diagnosed post-mortem. Dr. Stern, who's out of Boston University, a neuropsychologist, anticipates that within the next 5 to 10 years, it's likely that there'll be an intra vivo diagnosis. So we can determine who is at risk of having CTE, what protections need to be made. So that first lawsuit that was filed was kind of an eye-opener for media and the public about, wow, these giants that we're so used to, the heroes that played on the gridiron on a daily basis, they're now suffering from these injuries. And I think that was also a pivotal moment in society, because prior to 2011, I think a lot of people thought that a concussion was just a ding. Concussion is a brain injury that must be managed properly. Otherwise, it could have catastrophic results. And I think this litigation has really brought on a new sense of awareness to concussions, the potential long-term effects that it has on an athlete. And so I think this litigation has been very positive. It's unfortunate that it often takes litigation or legislation to enact change, but at the same time, I think it's a real force and a real measure that we need. And I wanted to identify two parallels that I saw in the other discussions that we had today that go to that point, and especially as there's lawyers in this room and law students. But one was the idea of, for the military, it looks like there wasn't a realization of brain injuries until 2008, 2009. And still, I mean, the education around it is so far behind. And why it's taken that long is frustrating. And secondly, is the idea of this arduous and arbitrary and unfair process that it appears that veterans must go through just to get benefits that they clearly deserve. I mean, they're the ones that put their life on the line. And as lawyers, I think Sean hit on this earlier. It was basically, I saw it as a call to action. As lawyers, we must be willing to step up to the plate and protect these guys that have protected our country. And I very much look forward to watching this CLE later on this afternoon so I can learn about the benefits and how to get involved and start representing these veterans, because they so need our service, because we appreciate so much that they've done for us. So that's all I have, and I just want to end with this one final point that, again, if we want contact sports to continue to thrive and survive, because there's so many great things that come with sport, but if we want football to thrive and survive, we must first acknowledge that there are serious ramifications, and we must be willing to accept, that we can no longer take this denial, this idea of denying that there's any link. Instead, we must accept it, and then we must figure out how to ensure that the rest of the public understands and knows these concerns. And we must be willing to accept the change that's needed, such as going back to that simple idea of limiting contact practices. U.S. Soccer just entered into a settlement a couple days ago, which is going to limit the amount of headers that individuals are allowed to do, because concussions are not limited to just football. Concussions occur in our daily walk of life, as well as in other sports. And the idea of awareness, which was mentioned earlier, that really needs to come to the forefront about how serious brain injuries can be. And I think Marvin's going to be able to touch on living through that. And then Professor Abrams is also going to talk about kind of the trickle-down effect the NFL concussion litigation has had. Thank you.
I'm Marvin Washington. Like I said, I'm a veteran over 10 years in the NFL and playing the game. And one of the things that I when everybody's saying it's a contact sport, I know what a contact sport is. That's basketball, that's soccer, it's baseball, but football is a collision sport. I know it, and I played it, and you're having thousands of collisions with big, strong, fast guys that are going 25 and 30 miles an hour. And so I just want to tell you a little bit of my story and how I see concussions and CTE, the NFL from a historical standpoint and even a current and a future standpoint. I turned 50 years old this year, and so I've been watching football since the 70s with my dad. He made me a Dallas Cowboy fan. I'm happy he did that at the time, because we had a pretty good run there, but especially during the 70s. But when you watch football during the 70s, it was still coming out of the 50s and the 60s, and linemen were still 250 pounds and 260 pounds. And I believe they were still playing the game correctly from a physical standpoint, because they were doing a lot of shoulder tackling and proper tackling of the lower body, and you still hadn't gotten to the point where guys were doing that head hunt, which came later. That started to change a little bit during the 70s, because you had teams like the Steelers and the Raiders who got better football through science. And so now you start to get the linemen going from 250 and 60 to 270, 80, and 90. How did they do that? Well, they got their science from Eastern Europe and coming out the communist bloc, and Russia's having an issue with it now. They're still doing it, but it was blatant back then from John Matuzik and Lyle Alzado and those guys. And then you start to see the game started to get more physical, especially with the Steelers and the Raiders. You had headhunters from Mel Blount, Donnie Shell, guy got paralyzed, Darryl Stingley got paralyzed by the Raiders because they were doing headhunting. These were legal hits in the NFL. Then you come up with the 80s, guys were getting bigger, and then you had these anomaly guys like LT came into the league in 1981, I believe, and he was 6'4", 250, and he could run a 4.4, 4.5 40. You have Reggie White coming into the league in the 83, and he's 6'6", 290, and he's running that. And so guys started getting that, but it didn't take off. You had the Hogs, Washington Redskins, they won 3 Super Bowls during the 80s, and they had the big linemen. But the biggest hog was like 290, 295. And so then I came into the league. I was a fan. I played basketball for 3 years, and I played 1 year of college football. And I was had enough, potential, and they saw something that I got drafted. So I came into the league in 1989. When I came into the league in 1989, you had 4 linemen, offensive linemen, over 300 pounds. When I left the league in the year 2000, you probably have 4 linemen or 3 linemen that were under 300 pounds. And guys were getting bigger and faster and stronger, because I went from my rookie year at 255 to my 3rd year, I was weighing 280. Because that's the way it was, because football became year-round. The training became year-round. And I'm gonna be honest with you, I got better through chemicals also. I was a proponent of HGH my first couple of years in the league, because I had to get big, because if somebody was gonna get hurt, it wasn't gonna be me. But you saw guys started taking off, during the 70s and the 80s. If you look back in the film, guys had neck rolls and arm pads and all that, but you started seeing as guys got bigger and trying to play as fast as they can, all that started coming off. And they started taking the pads out of their pants and the arms, and you just had shoulder pads and basically your helmet, and that's what you used. And I never came up, and we never had a concussion protocol. It was something you got your bell rung, you got back in there. I have 3 concussions in my medical record. I had one that I remember. I got knocked out, and when I came to, I was sitting on the sideline, and that rheumatologist that was the head of the NFL's neck and spine committee, that was our team doctor, Dr. Elliot Pellman. And he asked me where I was, and I'm looking at the scoreboard, and I'm like, yeah, we're in New England. And he was like, you know what the score is? I was like, yeah, what quarter it is? I'm looking at it, and he says, goal line. And so I was on the goal line team, so I grab my helmet, I run out there. But I'm still kind of dizzy and whatever, so what I do, I get down on my stance, and the 3 points of contact since the 40s, 50s, 60s, and even now, 3 points of contact in the NFL for a lineman is this hand, and this hand. This is what you're leading with. And so during that game, I stayed in the game, and this was usual. This was standard operating procedure back then. I stayed in the game, but how did I get to the game, through the game, because I couldn't remember anything. Every time I get down on my stance, I turn back to the linebacker who had just given the play. I would turn back to him, I said, what's the defense? And he'd tell me, and then I'd be able to remember and go through it. But I don't remember that game. I don't remember the plane ride home. I don't remember watching film Monday. During that week, it started to come back to me, but I was still a little queasy and whatever with my head, but I had to play, and I took aspirin, and they gave me some for my nausea, whatever, but I played, and that's the way it was. You got your bell rung. Getting your bell rung is when you hit helmet to helmet, and you kind of see stars, and you don't know how to feel, but you're not supposed to feel like, yeah, I'm hurt. Because you knock a guy, you hit a guy really hard, and you're getting high fives, and coaches tell you attaboy and whatever, and you're like, okay, this is the way it is. Welcome to the NFL, rookie. Welcome to the NFL. That's how it was back then, and it's still prevalent to this day. And so I went through the league, and I seen guys, we had no concussion protocol, and I still say we were the guinea pigs. Because the NFL, what did they know, when did they know it? I think they kind of knew, because that's why they formed that committee and whatever, but they were still denying it. Once I retired in 2000, got on with my life's work, then I started hearing about the problems Mike Webster were having, and then the issues that he had in his life. And then it came out that, you know, he had this disease, and this doctor was saying about it. But I'm just looking at it. It was pre-internet and what have you. And then you had the next guy I knew about was a guy named Andre Waters, and he was a big hitting safety for the Philadelphia Eagles. They call him Dirty Waters because he put the hat on you, and that's what it was, putting the hat on you. And then he was coaching in a college. Then he dropped off the grid, and next thing you know, he committed suicide. Then you hear about Terry Long, another guy, and then Dr. Malo comes out with his discovery, and you read about the hell that the NFL put him through, and then he comes out with it, and then you see the movie of The League of the Now, but guys are still dying from this. And now you have our attention. You really got my attention when Dave Dorson was a Notre Dame grad, Chicago Bear, longtime player, good businessman, just a solid guy that, you know, the NFL always talks about protect the shield. Well, this is a guy that protected the shield and was representing the shield. And then CTE is a disease that's cumulative. It starts to go down, and he started to go down. And it's the normal course that from these guys that you see, from impulse control, domestic violence, depression, anxiety, and then Dave Dorson shot himself in the chest. And it's like, what? Wait, what? This is a real deal. So we started to get, you know, on the NFL underground, we started getting, and then the concussion lawsuit came along. And I think a year or two after the concussion lawsuit, Junior Seau, you can't tell the history of the NFL without Junior Seau. Played 20 years, middle linebacker, but what was he leading with? If you wanted somebody to plug that hole, you're meeting Junior Seau for the Chargers. Very intense, hard-nosed player. He shot himself. So now we know it's a real deal. They filed a lawsuit, and players we're optimistic about it, but we know that the NFL, with this lawsuit, they're going to have to recognize it. They're going to have to do something about it. And then we get another kick. Well, I get another kick in the gut when I looked at the settlement. There was a settlement for the NFL, the concussion lawsuit, and they left CTE. It's written out of the settlement. And so that's like construction workers getting together with the asbestos and they leave mesothelioma out of it. Or coal miners, you will cover heart disease, we'll cover stroke, seizures, but black lung disease we won't cover. That's what happened and with this settlement, but players are still going around thinking that the NFL is going to take care of it and they're going to get all this money. That's a misnomer. It's misleading. The NFL had better attorneys than the players did. I think the players' attorneys, they sold us, the ex-players, they sold us down the river. You know, who gets paid out of it, follow the money trail. Within 9 months of the settlement being approved, and there's still some issues whether it's going to be approved or not, the lawyers get $112 million. There are going to be so many procedure hoops and hurdles that players are going to have to go through that only 19% of players are going to get paid. And you hear this number of $1 billion. It's not $1 billion. It's a horrible, horrible settlement for players, and especially players that suffer through CTE. And to tell you how I explain it to people, I say if Junior Seau was alive right now, he wouldn't get 1 cent out of this concussion settlement. That's how bad it is. But I am optimistic because the NFL is driven. We have a financially driven commissioner now that is, his mandate is to make sure the NFL's bottom line keeps increasing each year. The NFL is a $12 billion industry right now. They want it to be $20 billion by 2025, but how are they gonna do that? You have to make sure that the game is safe. This movie that's coming out is gonna bring a lot of awareness to this issue. It's gonna put it into the mainstream where women who are casually football fans, they're gonna go to the movie because it's Will Smith, it's human interest. Your husband's gonna take you to, and you're gonna take him because it's football. You're gonna see this movie. You're gonna see what that's what it is. Will Smith may win an Oscar for this movie, but you're gonna see what the NFL, how they attacked it and how they're still doing it. Because for a while there, and it still is, the NFL was known for deny, delay, then you die. That's what they're gonna do. But I believe that if the NFL wants to grow their game, if they want to take it across the pond and have it, you know, an international game, they're going to have to do something about their industrial disease, which is CTE. This is something that's going to affect their players. They have the money to do it. They're not going to be able to deny it. If I had, you know, my oldest son is 22. He played at LSU, big-time college football, what have you. He's in the CFL right now. But my youngest son is a senior in high school. I wouldn't let him play football. I believe strongly that you shouldn't put on a helmet till you're probably about 16 or 17. And I know that's going against the norm. And I don't want to kill football. I just want to make it safer. I don't believe these kids that are walking around with unsafe, substandard equipment that they got from last year, that's still in use from 3 years ago, that somebody else is ill-fitting, whatever, and they're still going out there banging their heads. They're getting sub-concussions. They're dying from concussions. And the NFL has to lead the way because the NFL is the biggest ship in the water. College game is going to follow it, and high school, and these high school players that emulate the grown-ups that they see that's playing this man's game. It's not a kid's game, it's a man's game. That, you know, they have to lead the way with the cognitive closed head injuries that these players are suffering and we're suffering from. And there's two ways it's going to be done. It's through equipment and I think science. And I really don't know if you can make a helmet that's going to protect the brain. Because once the brain once you're having these collisions and you make that sudden stop, everything's going to stop except your brain on that stem. So I don't know if it's going to come that way, but I know there are companies, and Dr. Bennett Amalu is, and this is not an advertisement, but Dr. Bennett Amalu is on our board. I'm with a company called Canon Life Science, and we have a patent from the NIH, United States government, to develop a chemical out of the cannabis plant called cannabinol, CBD, as a neuroprotectant and antioxidant for the brain. I'm talking to the NFLPA. They're aware of our work and what have you, so I believe within the next 5 to 10 years, we will have something that will be a neuroprotectant for the brain and curative also. But yet and still, we need to cut down on our kids that, you know, from age 5 to 6, and I've seen them, they're in their helmets, and I'm like, what the I drive by these football fields, or these little Pop Warner football fields, you have these kids in full uniform, being coached by coaches that, you know, that are not qualified to do anything, especially not coach your kids, to coach your kids. And I just want to say, like, as Sean said, get the awareness out about this. I believe the movie's going to do a lot. But I believe we're in this together because I believe if whatever comes out of our lab and comes out of Boston University, it's not only going to help football players, but it's going to help veterans like Alex because we need it and they deserve it. And so this thing is an exciting time. Over the last 5 to 6 years, it's going to move along because I believe that the Department of Veteran Affairs there recognize it, but the NFL is still denying it. But there's not going to be any denial when it affects their bottom lines because since the concussion lawsuit was filed in 2010, youth participation in football has gone down 25%. And so if that keeps on that arc, then where are you going to get the players from? It's going to be a niche sport because in the 1950s, the top 3 sports were boxing, horse racing, and baseball. Baseball's doing fine. What about those other 2? They're events now, Kentucky Derby, Preakness, and then if you have a Mayweather fight or whatever it is, that's where football could be heading unless they get ahead of this problem and get a handle and take care of their former players with this closed head injury issue. So I appreciate you guys. I want to thank the veterans, say Happy Veterans Day. I appreciate your sacrifice and your service and the families. And I want to thank Angela for having me here, for letting me spread the word and bring awareness to it. And like Sean was saying, like you post something on Facebook about CTE, post something on Facebook about TBI, and let's move this forward. I want to wish Paul and his firm all the luck because they're out of the concussion lawsuit, and if something's going to come about when the NFL knew it and what did they know, it's going to come from him, and it's not only going to benefit the players that they represent, it's going to benefit all the players. I believe at all levels. And as I said, I love football. I just want to make it safer. for people that plan it. And if you have kids and what have you, really take a long, hard look about letting your young boys go out there with those helmets on. My son that plays, he didn't start playing football and put on the helmet until he was in high school. That's something that all parents should consider. And the moms, you guys are, you know, you guys are the decision makers in most of the households. So thank you for having me, and I learned a lot, and I look forward to, you know, keeping this, bringing awareness to this issue. Thank you.
All right, well, first of all, thank you all very much for coming today. I am used to teaching, and I teach in this classroom 4 days a week, every day. I use notes, and so I've got a few here. First of all, I'd like to thank Professor Drake and her devoted students, and they are truly devoted. I see what they do from day to day. I wondered when I first saw the flyer why she was linking athletics to veterans and a veterans clinic, but I think it's pretty clear today what the link is. And Gordie Howe, the great hockey player, once used to tell kids, you've got 2 ears and a mouth, and if you keep your mouth closed and your ears open, you'll learn a lot. I'm going to try to contribute something in the next 15 or 20 minutes, but I've learned an awful lot today. It's an awfully great array of speakers. I'd like to thank the clinic for 2 reasons. One of them has to do with citizenship, and the other one has to do with public health. First of all, citizenship. It is a national obligation to provide veterans the care that they were promised and that they deserve for what they did. In every war that we've fought in our history, there's always been debate during the war, and there's been debate during the Iraq and Afghanistan wars, but it should be inviolate and beyond debate to provide veterans what they deserve, not just in TBI. Today's conference is TBI, but there are plenty of other injuries as well. So that's the citizenship point of it. Public health point of it, both Marvin and Paul have talked about the NFL. They're much closer to that than I am. I never played football. I never coached football. I coached youth hockey for 40 years, but and they've got their own concussion problems in hockey. But I never did, I never did football. But I see a great link between what's going on in the NFL and what's going on in youth sports as well. The professional ranks set the example. They set good examples, they set bad examples, but they set examples. And I can only wonder how many kids have gotten hurt in the past 10 or 15 years because the NFL has been in this league of denial mode that has just been talked about, where if they came clean earlier on, 10 or 15 years ago, some of the youth leagues would catch on. There's been an awful lot of research and development in CTE and concussions, much of it in the last 10 to 15 years. I was just telling Paul and Marvin on the phone the other day when we were doing our preparation. In 2004, a guy named Michael McCambridge wrote a very good book, 500 pages long, on the history of American football, the NFL and its predecessors. This was 2004, 500 pages, and the word concussion did not show up in that book at all. And that was 2004. So what do we have today? We have a lot of cross-pollination today, and I think this is very helpful. There's an awful lot of research, and I'm not a doctor, but boy, I'll tell you, I'm in awe of what the medical people are turning out in terms of quality and quantity and commentary and research. A lot of this deals with the military. The Defense Department, as I understand, is very active in research and head injuries. Much of it has to do with sports, not only professional sports, but also youth sports. And there's an awful lot of cross-pollination with researchers who do both. And this cross-pollination has to continue, because I think one of the things that the researchers are finding is that brain research in combat and brain research in youth sports and adult sports have differences for sure, but also commonalities. And a lot of what the research is developing is coming from youth sports today. Let me just give you a little background and hit you with some numbers about youth sports, because as you probably know, may not have thought about it, most athletes in America are not professionals, and most athletes in America are not adults. Most athletes are kids. 35 million children play youth sports in one team or another in any given year. We have about 73 million children in America, but that includes the ones from newborns up to 18. If you just take a look at the kids who are between the ages of 5 and 18, about half of American children play youth sports every year. So that's one of the reasons why one of the most fertile areas of brain research has been in the youth sports region, youth sports area, because it really is a public health crisis when you've got that many kids, and it's not just football. I mean, football is number one when it comes to brain injuries, concussions, but hockey, soccer, basketball, lacrosse are not that far behind. As a matter of fact, boys football is number one in youth sports concussions. You want to take a guess about what number two is? Girls soccer. Girls soccer. And boys soccer is not that far behind. So when you talk about 35 million kids playing sports, and concussions can happen in almost any sport, you're talking about an awful lot of kids every year who are exposed to what can be a very can get to be a very serious injury. Now, just in football alone, and I'm not very good in math. Matter of fact, I'm very bad in math. But it seems to me that about 90% of human beings who play football in America are children. More than 3 million children play Pop Warner and high school football. And when you get to the adult level, the NCAA estimates that about 70,000 people all over the age of 18, adults, play football. About 1,700 play in the NFL, and there are some other leagues as well. But when you get down to the brass tacks, you're talking about 90% of football players who are children. And I think that you've just heard some very thoughtful stuff. I know you've just heard some very thoughtful stuff from Paul and Marvin about how playing football at such young ages can really cause a problem when you're talking about tackling when the kids are about 6 years old. Now, I will tell you, and this is not what I came to talk about because it's a veterans clinic, but some of the worst enemies of kids who play sports are their own parents and their coaches. Paraphrase Tip O'Neill, the former U.S. Speaker of the U.S. Congress, Speaker of the U.S. House. He said that all politics is local. Well, all safety is local too. The national governing bodies, USA Football, USA Hockey, USA Soccer, they can, and they do, set safety standards that apply nationwide. They modify the rules without changing the character of the game, but they modify the rules so that kids can be safer. Well, USA Hockey, the NGB that I'm most familiar with, is based in Colorado Springs. And you can be darn sure that they don't know, and there's no way for them to know, what goes on in an ice rink in Albuquerque, New Mexico, Portland, Maine, or Miami, Florida on a Thursday night. And you have great rules. They have to be enforced locally by referees, parents, and coaches. And you got an awful lot of injuries that happen around the country when parents go haywire in a game, when the game gets out of hand, when the referees lose control of the game. And it doesn't matter what the NGBs say in Colorado Springs or anything else. It's like building a building. You build a great building, you can implode it. It may take years to build the building, but you can implode it in a few seconds. So in order to make sports safer, football and the other sports safer, you not only have to have the rules changes, you have to have coaches who are somewhat trained in the rules, and Marvin is 100% right. Many of the coaches, some of you probably have done it, you're an interested parent, you get dragooned into coaching because nobody else wants to do it. You go to a one-day clinic to learn how to coach. Most of the time, the clinics, the ones I've gone to, you got 20-something or 30-something instructors who want to show you all the X's and O's, and they spend very little time with health and safety. And then you have to go out and perform. And again, in Colorado Springs, there's no way for them to know what the quality of coaching is in a particular place in the country on a Thursday night or a Saturday morning or something like that. And for those of you who sometimes complain, or you have no parents who complain about, well, the referee stinks. Well, a lot of times the referees stink in youth sports, and they're unable to keep up with the game, particularly in the older age levels in contact and collision sports, is because there's a mass exodus of referees out of refereeing every year. They quit. They're sick and tired of the abuse that they take from parents and coaches. So you got a lot of referees out there who aren't quite ready to be out there, wouldn't be out there if the veteran referees stuck with the game. Well, anyway, that's my soapbox. That's my soapbox for youth sports. But this is a veterans clinic, so let's stick to the veterans clinic part of it. I want to talk about two issues before Justin, the MC here, the moderator, pulls out the vaudeville hook and tells me my time is up. I want to talk to you about two issues that I think are common, both to research in sports and also research into brain injuries with the military. The first of the issues is common sense, or at least it should be. The second issue may not be. But the first issue is we have to keep learning, and it's got to be a work in progress. Medical research has to be a work in progress on TBI. Let me give you a little bit of history. Let's do football first, and then we can do the military. In 1905, Theodore Roosevelt was still president. 1905, 18 college football players died on the gridiron playing football. That's a lot. Today, if one player dies of the 70,000 that play NFL and NCAA football, that would be nationwide news. 18 is an astounding number anyway, but it's an astounding number particularly because the number of college football players was so much smaller back in 1905. And it was a big deal because that college football was football in those days. The NFL didn't come around until the early 1920s. So Theodore Roosevelt got worried. His son was playing freshman football at Harvard. He had wanted to play football when he was at Harvard in the 1880s, but he was nearsighted. So he called a White House conference of the Big Three. The Big Three football powers in those days were Harvard, Yale, and Princeton. The arrangement has changed a little bit. He called a conference to change some rules and to make football safer because there were calls to abolish football, that it was barbaric. And to this day, the NCAA's highest annual award is the Theodore Roosevelt Award. They know he saved football. Well, anyway, change came very slowly. One of the reasons why guys were dying on the football field of what today would be some version of TBI was because, number one, they didn't wear helmets, and number two, they wore very flimsy equipment if they wore any equipment at all. Here is a picture of a college football game between Iowa State and Minnesota in 1923. You'll notice that number 44 on the left isn't wearing a helmet. Helmets didn't become mandatory in the NCAA until 1939. And you look at the evolution of football helmets, you can see that the evolution of safety, and the game was different in those days, I'm sure too, but Marvin has talked to you about the weight gains just in his period of time. But just take a look at what these guys were wearing. Here's an early 1930s football card, a Gowdy card of Red Grange, who was the star of the 1920s and 1930s. You wouldn't let a kid wear this in a touch football game today. That's what his helmet was in the 20s and 30s. In the 30s and 40s, that's what Sammy Baugh wore, and that passed for a football helmet. Johnny Unitas was wearing something better by the 50s, 60s, and early 70s when he was playing. This is what the guys were wearing in the early 1990s. Anybody want to guess who that is? Marvin, you didn't think you would get away scot-free today, did you? That's Marvin Washington. They're wearing better equipment by the 1990s. But it took sports, and the same thing in the sport that I coached. I mean, in hockey. You look at my family scrapbook and look at what passed for good equipment when I was playing youth hockey in the 1960s. It's laughable today. So we are still learning, and we still have to learn. Now the military, the same way. We'll turn to the military here. About 10 years after Roosevelt held his White House conference, World War I became the biggest bloodbath that the world had ever seen. It was the first total mechanized war. Millions of casualties, and the United States and every other country in the world was thoroughly unprepared. Medical science was thoroughly unprepared for what was going to happen. So everybody has, at one time or another, probably seen pictures of shell shock. Here is shell shock in France in some trench in 1916. Didn't know what shell shock was. Well, today we know that there's some version of PTSD, but we didn't know that and medical science didn't know that at that time. And you can imagine how many American soldiers and how many soldiers in other countries came home with looking like this, the blank stare and everything else that we now are able to diagnose a little better than we did before. Well, you fast forward to Vietnam, when we really did shortchange an awful lot of veterans who came home with physical or emotional distress. Now, part of that reason was that Vietnam was an unpopular war, it was a long war, it was an unpopular war, and there just wasn't the national will to give veterans what it is that they had deserved and earned. But part of it was also that medical science, even in the 70s, wasn't what it is today. And 10 years from now, it's going to even be better than it is right now. But the point is, even in the Vietnam days, things were that medical science didn't give these veterans what it is that they deserve. Now, the second factor, the second issue I wanted to talk about very quickly, directly has to do with some research that has come out in recent years from youth sports medical science concerning TBI. There is some evidence, and probably a lot of evidence, that traumatic brain injury in children and adolescents can be much more serious than it is in adults, because the childhood and adolescent brain is still developing. Now the brain, and there's been some other medical research that indicates that the adolescent brain doesn't stop developing when the adolescent reaches the general age of majority at 18, that the brain continues to develop until about the age of 24. And that second concussion, second impact syndrome, and time for cures and the dangers of a second hit can be much more serious for somebody under the age of 24 than for somebody over the age of 24. Now, I'm not a doctor, but this is something I think the military should continue to pay attention to, because there are an awful lot of veterans who come home who are injured when they are under that age. So in any event, these are some of the things that come out of youth sports research. There's been so much research in youth sports concussions because there are so many kids playing. It can happen in almost any sport. and there is an overlap between sports, youth sports, and the military. And I'll just leave you with this quote from Jesse Ventura, who you know was the former governor of Minnesota. You may or may not know that he was a Navy veteran of Vietnam. He wrote this in 2007. He wrote it in an introduction to a book on youth sports concussions, but if he was writing about military concussions with a couple of changed words, he could say pretty much the same thing. So in any event, thank you very much again for listening to me for a few minutes. Thank you for the clinic and what Angela and her students do. If this is your first experience at our law school, you see one of our very good students right here about ready to take the microphone from me, and he is one of our very good students. This is a good place, and we hope you all come back.
Open it up for questions for any of our panelists. Does anyone have a question? I'll bring the mic around. No. We all good? All right, well, can we get another round of applause for our panelists?
Test, test. Okay, let's have a seat so we can stay on track because we have another great panel. And then we're going to take a break before our keynote speaker. So great to see the room so full. Everybody, welcome to Mizzou Law. Welcome to the TBI Symposium. And I'm going to now introduce the moderator for the next segment, and he will introduce the panelists, and this is my suite mate. The Veterans Clinic is awesome, but we share space with the Entrepreneurship Legal Clinic, which is also awesome, and Jim Neiman runs that clinic, and he's a joy to work with every day, and I very much appreciate him being such a terrific colleague and being a part of our symposium. That's how we roll in our clinics, so thanks, Jim.
Thank you, Angela. And I can't let Angela go without pointing out to you how outstanding the work that she does and her students do right next door and in the same area that my students have been starting up businesses in the Entrepreneurship Legal Clinic. And she's very forward-thinking. She has care for her clients and her students, and especially the clients, beyond what her job really entails. So she came up to me recently and said, you know, let's think about ways that we could actually collaborate between our two clinics and have the Entrepreneurship Legal Clinic offer a tangential possibility for veterans to start businesses. And so we are pursuing that as well. If veterans are in the audience that are interested in innovating and getting into their own business in a couple of ways. We've talked about how that can be a great fit because oftentimes the work environment of being an employee isn't the most receptive to all the struggles that our veterans go through after they've come back from the amazing services they've given for our country. So being a business owner has all the opportunities in the world to create a different environment for them to succeed. They're also leaders. We've talked in terms of franchising how well-suited they are to be franchisees because they are used to being regimented and follow rules, and that's what happens when you have a franchise of a major franchise operation. You're able to have the rules set forward, and your business operates pursuant to those rules, and you're able to be successful in that regard too. So I applaud Professor Drake and all of our students for the wonderful work they do. That was my unabashed plug for both of our clinics, but as Angela told me before this, it's not about me. It's about the panels, and I am merely a moderator, which I did look up, and it means moderator or judge, and then there was something that said I have to endeavor to quell melees that might take place. So I looked at Michael and Rex, and I said, I hope there's not a melee. But I know there won't be. I know Michael real well. I'm proud to consider him one of my very good friends. And Rex I've just met, and am very proud to know Rex as well. And I'm going to tell you a little bit about him. Is there a way to cut the PowerPoint and maybe turn on the lights, because we don't really need the PowerPoint projector? Thank you. I appreciate that, Scott. And we can turn on the lights because I know they've probably been dimmed because of the PowerPoints. So that's a lot better. Now you can see these handsome gentlemen down here, the stars of the show. So without further ado, let me tell you a little bit about Rex Sharp. Rex Sharp is an associate athletic director at Mizzou. He has held that position since 2011. He has also been at Mizzou as the head athletic trainer since 1996. He is responsible for being a part of leadership for the concussion protocols that the entire athletic department utilizes, and he's been nationally part of the vanguard that has brought that about in college athletics. He is a graduate of Ball State University, where he had been the head athletic trainer for 11 years prior to joining Mizzou. He is also a graduate of Ball State University graduated magna cum laude. He is adjunct professor here at Mizzou in the Department of Nutritional Sciences. He teaches 3 courses. He has a number of his students and trainers here today. Can you all raise your hands or stand up? Very good. And so I've told them I'm probably going to call on them at some point in time. The Socratic method doesn't come out of the professors very easily. Rex also is the husband of Eileen. They have 3 children, daughter Audrey and twin sons, Adam and Jared. To Rex's left is Michael Sam. Some of you might have heard of him. Like I said before, I couldn't be more proud to know him as a person, as a friend. I fortunately wasn't introduced to him through a lot of the fame and fanfare. I've gotten to know him as a person, and by far his greatest traits lie in his value as a human and as a concerned member of the Mizzou family. He is an NFL player. I told Michael I was going to introduce him as an NFL player because he's played in the NFL, and I truly believe in my heart of hearts that he and his determination will land him back in the NFL. He's proven his drive as a Mizzou football player. He's also a unanimous All-American from 2012. He's the SEC Defensive Player of the Year in 2013. Actually, both of those were 2013. And he's the Arthur Ashe Courage Award winner. I would like to not go down too many more of his accolades. I could be here probably for another 10 minutes just listing the highlights. But again, my view personally of Michael is not on his past accomplishments. My perspective on Michael is the bright future that he has, and which includes his participation here today and Rex's participation here today. They're here because they believe in the education that's taking place at the University of Missouri, not just on the athletic fields and in the athletic department, but here in the colleges and the schools that we all participate in on a daily basis. So I'm going to we're going to do our panel a little bit differently. I'm going to put a microphone between the two gentlemen. I'm going to kind of lead a little bit of discussion. And I hope as you get to hear about the wonderful things that Rex has done for the athletic program, I've invited Michael to provide his comments along the way, have an interactive dialogue as we go through it. So without further ado, let me turn the mic over to Rex and let him tell you a little bit about the concussion protocols with the Mizzou athletic program and the history of how it came about, the impact of it, and whatever else you want to talk about.
Thank you, Jim. To touch upon our concussion management plan here at the University of Missouri, the genesis of that plan was started probably about 10 years ago when I had an opportunity to be one of the 10 athletic trainers in the country on a national committee for sports safety. And we began talking about spearing, which is a thing that was going on at that time in football, someone leading with their head and spearing their opponent, and that's a risky type of mechanism of injury. So we were talking about that, and we had several expert guest speakers come and talk to us at that time, just the committee itself. Joe Torg, who's a physician, Frederick Mueller's a physician, and then Kevin Guskowitz, who's nationally known for concussion research at the University of North Carolina. And it occurred to me that we needed to do something different here at Mizzou. And so we began to put together a concussion management plan, which is really the gist of that plan is education of our student athletes, awareness of the problem among our student athletes, and then, of course, some prevention and recognition. And so we talked to our coaches about teaching proper technique. We talked to our athletic performance staff about neck strengthening and other exercises that might help to prevent the risk of concussive force with rotational velocity. And then we also talked to our student athletes about the importance of utilizing proper technique. And two things. One is looking out for their teammates, and the other thing is to make sure that they report if they have an issue. And I think that together, in the last 10 years, we've come a long way. The concussion management plan is still evolving. I think the newest part of that plan that really wasn't in the initial plan was the return to learn. You know, what are we going to do with someone who's sustained an injury? How quickly do we incorporate them back into the classroom? And that's something that we've been working on quite a bit over the last probably year and a half, the return to learn protocol that we use to allow an athlete to go back into the classroom. Certainly if you go back too quickly with cognitive activity, that has shown to prolong the concussive symptoms. So it's real important, I think, to have a return to learn protocol, and we think we have a pretty good one here at Mizzou. Our program has been modeled around the country. I'm real proud of that. So that's kind of the gist of what we're doing here at Mizzou. Michael?
I am a Texas native, and I was just telling Rex and Jim this earlier. If you play football in Texas, you most likely watched this movie. It's called Varsity Blues. So the first, I heard some giggles. And the first time I ever heard about concussion was when Billy Bob had about one more concussion left, and it was on the scoreboard. So every time you get a concussion, it was kind of like, oh, well, Billy Bob only has like a certain amount of concussions. I never heard, we never really preached about concussions and not junior high nor high school. It was something like, didn't really was said. If you got hurt, you probably just most likely would see a trainer. A trainer was probably send you to the hospital, and they would determine if you had a concussion or not. Until I got to the University of Missouri, that was really when I was educated about concussions, not only through Rex and his team, but also through our coaches. And Rex mentioned not too long ago about the proper technique and education that was taught. And over the years, I never experienced a concussion at the University of Missouri, nor in high school or junior high. And I really, or my brief time playing in the NFL, I'm really fortunate on that, just because what I learned through the University of Missouri athletic department, and just really blessed. But they've really taught me a lot, and I know some people who are not blessed to have such educators like Rex or my coaching staff, and just really fortunate went to University of Missouri.
I was going to say, one of the things that I know validated that what we do here occurred actually, I think, in Michael's freshman year. We had a student athlete on the football field, and we were playing here at home, and it was a big play, 3rd and 6. And we had a running back at that time that was given the ball, and he went crashing through the line and ran into the safety for the opposing team, made a heck of a collision. And he jumped up, and he was really giving it heck because he got in the first down. It was exciting. And of course the crowd's responding, and we finished that drive, we scored. The other team, we kicked off, the other team had 3 plays, then they punted back to us. And we were on our sideline, and one of his teammates came up and said, Rex, you really need to go check, the student athlete. And I said, well, what in the world happened? And he said, well, he's out of it. He doesn't know where he is. And that is exactly what we want. That's exactly why we do this, is to educate the teammates on helping to look out, because there is absolutely no way that any of us would have thought that that young man had had a concussion based upon his response to that play and his finishing that drive. There's just no way. So we were able to effectively deal with that thanks to the education and recognition that our student athlete assisted with, and I think that's exactly why we do this.
The other mic's not working, so I'm going to keep on grabbing it back and forth here. We're sharers, so that'll work out just fine. One fact that might surprise you about this group, and it's also something I want to make clear. Michael Sam's not here because he's the one down here with a concussion. There's only one person down here that's had a concussion, and that's me. So I used to play football when I was in college as well, not on Michael's level. I was more like when he was a 8th grader, the water boy for the varsity team. It is a true fact. Did a little research on Michael. Water boy for the varsity team as an 8th grader. Distant memory. But when I was at Notre Dame, we had full contact football with the dorms, and that was prior to trying to walk on. But I had gone downfield on punt coverage and had a beeline on the receiver, had a full head of steam, and he caught it just in time with the halo rule to be able to lean forward, and the head-to-head contact, because I was always trained, put your face mask right in the person's numbers. When you duck your head, you end up having spearing on both sides. Rex and I were joking about how we don't know who the penalty would have been on. But I want to be clear, Michael Sam is not here because he's been concussed. And you can tell by his performance as a sports personality and a commentator for KOMU that he is every bit the spokesperson for athletes when it comes to the not only the activities within the progress of the sports program, but also when it comes to player safety and the environment of players. So another thing that we were talking about was some anecdotal stuff. So I know a lot of you came in here to talk about Veterans Affairs and also the sports and athletics aspect of it. I did want both Rex and Michael to talk about their connections and friends and associates who have been military as well.
Clearly I'm a former athlete who played for the University of Missouri and, as I said, a brief time in the NFL. And I've never really met anyone who had a concussion. And I actually just learned, was it last week, Jim, when I came to talk to you, that I didn't know that military can get concussions neither. And I was completely surprised. I really thought that it was mostly just athletics. I knew football wasn't the only sport who can get a concussion, but I thought it was majority in sports. And Jim pretty much kind of gave me some knowledge about the gentleman who was speaking earlier about how his Humvee blew up in the air, and he lost his brother, and and he got a concussion from that, and I was completely shocked. And there's some other ways that, you know, the military can get concussion. I have not had a concussion. I have a brother, Ethan Pearl, who's serving as military police, and he's stationed out in Hawaii. To my knowledge, he never had a concussion neither. And my former coaches, Bruce Walker, who was a former coach for offensive line here, he served in the Marines, and also I didn't know that until you just told me that. But I also did, my former defensive coordinator, Coach Steckel, he's now the head coach of Missouri State. He also served in the Marines, and to my knowledge, he's crazy, so he probably had a couple concussions in the military. So, I wouldn't be surprised if he had a concussion. But I'm sorry, I keep on saying but as I said, I've never had a concussion, and just really, really fortunate in those. I just lost what I was going to say next, but I'm going to pass it to Rex. Thank you.
Well, obviously, a person my age, I've got a lot of friends and family that have been in the military, but Stack and Bruce and I actually all have talked about traumatic brain injury in the military before. And there's just no question that you know, there are a number of traumatic brain injuries that occur during training, as well as actually out on the front line.
So Michael also is the one of the three of us who has never had a surgery. So unbelievably, the man who's been through the athletic battles far greater than Rex or I ever have encountered. I think I can speak for you in that regard, right, Rex? Both of us have had surgeries. We've had injuries. Michael's had some Band-Aids. Speaking of which, the trainers here will appreciate this. One interesting thing we were talking about earlier was superstitions and certain pregame rituals that the players have. And both of the gentlemen have firsthand knowledge of that, and they're going to tell you a little bit about it.
Well, I'll probably defer to you again on this story at least. So.
Aren't any of your students, were they here when I was here?
No.
Good. Probably wouldn't like me. So we talk about rituals, and I have never had an injury. Well, never had to have surgery at the University of Missouri, and I'm really fortunate because of Rex and his team, who always took care of us and always got us to. I never missed a game neither, and they always took care of us. But our ritual, and it's always had to do with my ritual, and it's part of my routine. I always have a routine every week, and I've always had it since 2009. But I started playing in 2010, and usually those 48 hours and especially 24 hours, I do everything the same way. And when I need to see Rex, we have early taping at the hotel, at our team hotel. It doesn't matter if it's a home game or it's a away game. We always have early taping. And I will always be the last one to get taped. And Rex, and in the beginning, Rex will get frustrated because usually he actually wants people to get early tape. But at this point, he's like, well, you might miss the deadline. You're going to have to get taped at the stadium. I said, oh, no problem, Rex. But I usually always be the last one. And eventually he started leaving a couple rolls of tape just for me, and that was our routine. It was like I come, especially some other routines too. I would go into the medical room, and I'll have Casey will tape my wrists, and I'll get my shot, and it's just the same routine. And Rex he's all about the routine, and he about the superstition as well.
Yeah, the thing about Michael coming down late, I mean, we're at the hotel. I stay at the hotel on the night before the game with the travel squad. And so, you know, I have an associate that comes over and brings the supplies for ankle taping the next morning. And that associate has to go back to the stadium and you know, early. And I stay with these guys and come back on the bus, do the Tiger Walk and all that stuff. Well, anyway, it got to the point where we have our own little travel tables that are a certain height. And we take the travel tables out, and Casey brings those back to the stadium with him, so I'm taping off of a table that's about this height right here. So if I can't stand up straight after 4 years of doing this, you'll know why, because I'm bending over a table like this for 20 minutes to prepare him for a game. But it was frustrating at first, but then, to accommodate his pregame routine, while we wanted to make sure we could do everything we did to accommodate that.
I'll leave you with the microphone. Can you talk about Michael's game day personality a little bit?
Yeah, one thing about Michael is very, very intense, as a lot of our players are, and I'm very fortunate to work with a great group of people, not only as colleagues on the athletic training staff, but also with the student athletes. And my primary responsibility is with football, and they're great, great young people. And the one thing I do appreciate and learn very quickly is their 48-hour preparation, which Coach Pinkel talks about all the time. During that 48 hours, you need to be as focused as you could possibly be to play your best game. And Michael was an example of that. From Thursday on, he was a different person. And then on Sunday, he'd come back and he'd be like he is today. But I mean, you realize pretty quickly, or at least if you're very, very astute in this profession, you realize pretty quickly that, people's nuances as they prepare for a game. I'm sure that's no different than other places, but Michael was one of those that did have a certain 48-hour preparation.
Marvin, I'm very sure that you had your own routine as well. I wasn't very liked on game day. I was very intense, and that's why I said I hope your students were here when I was here. If someone threw me off my routine, I will get really, really frustrated, get really, really angry. It was just who I was. Everything had to be perfect. Everything had to be the same. I did the same thing every week. We get off the bus, we go on a Tiger Walk, I walk the same route, I put my bag down, I'm the first one out, I'm the first one in, I'm the first one to go see, to get undressed, I'm the first one to go get my wrist taped. I have to have a little spiritual message on my tape. The same person has to write that every week. When there's I will never forget when there was it was a freshman trainer, and it was his first day, and he didn't understand. He didn't know who Michael Sam was, and that's I kind of have to prefer myself to third person because I'm crazy. I'm crazy on game day. So he didn't understand how I was on game day, and I think I frightened him that day. I asked for Gatorade, and he gave me pickle juice, and I just looked at him in his face, and I'm not going to go in details, but I frightened him, and it's just who I am on game day, and I mean, it was my mind of thinking.
Actually, I think you threw the pickle juice in his face. I'm pretty sure. We use pickle juice here as a electrolyte supplement, by the way, in case some of you didn't know. You usually take about 8 ounces. Well, he did. He threw it in his face. So I do remember that.
Michael's never thrown any pickle juice or Gatorade or anything else at anybody up in the law school, so he's a reformed man. I do want to, I can ask him more questions, both of these gentlemen, but I'd like to give the opportunity for everybody who's here to ask questions. Does anybody have a question? I'll run the mic to you. Young lady.
Thank you. Can you address the role of the referees in trying to prevent terrible injuries to players and the education that they might get in order to keep people safe?
Great question.
That's a very good question. Now, in our league, in the Southeastern Conference, our officials they don't just start out in the Southeastern Conference. I mean, they work their way up. So with that, they've had a significant amount of opportunity to be educated on the rules. Not that they still don't make mistakes, because they do. But by the time they get to, I mean, a lot of them are my age or just a little bit younger, so they've been officials for a long time. And we have a Sports Medicine Association within the Southeastern Conference that meets with them in August. And in fact, they do a physical exam, they do a timed run, and then they do some rules education. And I think that most of them are very, very well versed. The rules that I get concerned about are the spearing rules, helmet-to-helmet contact, those things that can really lead to some significant injuries. But for the most part, I think that with their rules education, and it's continuing, this is not just a one-time, one-a-year thing, that it helps to prepare them for what they're trying to do on the field.
Rex, can you kind of speak to the improvement of helmets over the past 10, 15, 20 years versus like the mid-90s versus now? Do you think that's a good or a bad thing in relationship to what football players feel comfortable doing inside that helmet? And secondfold, and my second question would be, how far away are we from actually having digital tracking of what's going on in a student's brain within that helmet?
You're trying to trap me here, aren't you, Paul? Actually, the helmets will not prevent concussions. That's first and foremost. Helmets prevent skull fractures, but they don't prevent concussions. But the helmets have changed drastically since the mid-90s. When I would have come here, and even beyond, there's just a tremendous number of differences in the helmet itself. It's lighter, it's stronger, it's got some additional things inside that make, supposedly, protect your head a little bit better. But I think we're getting pretty close to putting some instruments inside the helmet to measure forces, and that's done in some places, but not universally, to measure the forces that the athlete takes on during the course of a practice and game. My focus has never really been on the one-time hit. It's on the accumulation of a lot of minor hits and what that might lead to. And that's what I'd really like to see someone study a little bit more. That's just starting to be done right now. I'll probably be retired by the time some of that data is available, but I will be curious and anxious to see that. Just some of the, we're always see the big hit. And people wow that and all that, but that's not the one that is really the most concerning to me. It's the ones that occur in the play of the line where they're making contact every single play, and the accumulation of those forces are what I'm really going to be anxious to see. And I think we're getting closer.
Way back, and I think Professor Greg has asked for one more question.
Hi, thanks. Sorry. My question is for Michael. So I did competitive martial arts for several years, and part of the thrill of the sport is the underlying danger of it. How does your knowledge of brain injury or concussions change your love for the game, or even your perception of the sport as an athlete?
Well, as an athlete, I'm also an entertainer too. That's foremost. I'm just an entertainer. When I step on the field, I know it's an entertaining sport. I'm aware of the dangers of going into that sport. I know that when I step on the field, it could be my last time playing in that game. I know that, and it's a risk that that I have to take. But going into the dangers, I try to do the right things. As I don't do any dirty. I only got in my career one personal foul call. That was a face mask back in 2010. I try to do the right thing. I try to tackle right. I was trying to play right. I never lead with my head, and that's just with the education that my coaches and Rex's team has taught. You do the right things, and these things can help you try to prevent any type of injuries. I don't know if you can ever really prepare for a concussion, because collision, it can happen. But if you do these things, it could be less preventable. I hope that answered your question. Sometimes I just like hear myself talk.
And we had a variation of that question when we were talking earlier too, when I put the question to both Rex and Michael about what's your stance on whether you'd let your kids participate in contact sports?
Well, yes. The answer to that is yes. I would, because but I would vet that out by saying that I would make sure that the training they're receiving from the coaches and the people that are supposed to be instructing them are doing it the right way. That's what I would make sure of.
And I agree too. I think I would let my kids play any type of sport as long as they get in the proper training and to help them prevent any serious injuries.
I've been instructed to wind this down, but I want to thank both Rex and Michael for their contributions to the symposium. the thoughtful advice that they've given, and again for Professor Drake for having us participate.
All right, 10-minute break, and then we'll hear our keynote, and you don't want to miss it, I promise. And then we'll be done with the symposium.